Association of Industrial Psychiatry of India. He has done his MBS and MD from Armed Force Medical College and PhD from Guwahati University. He has won 27 professional honors. Further is an editorial board member and a referee of 26 and 107 national and international journals respectively. He has published over 600 papers, 17 chapters, and edited 12 books and much more. We are honored to have you with us, sir. Our second judge is, thank you, sir. Our second judge is Dr. Shubhangi Parkar. He is a former head and professor of psychiatry at St. Joseph's Medical College for about 25 years. She has served as a dean and academic dean of her college and has played an instrumental role in starting a medical health helpline throughout the country in 2014, which was the first such helpline. She has many national and international publications, having more than 150 research to her name. Ma'am has received several awards at both national and international level, having the maximum number of awards in Indian psychiatry. She has contributed to the World Mental Health Book published by Hawra with Oxford University Press in USA. Thank you, ma'am, for being with us. So coming to the rules, all the participants will be given 4 minutes for presentation with a warning notice at 3 minutes and will be stopped if the presentation exceeds 4 minutes. This will be followed by judges' questions for about 2 minutes. Presenters are required to share the PPT from their side and switch on the mics and cameras while presenting. Please use headphones and ensure there's a good network connection. In case there's a technical glitch, the presenter will be allowed to present at the end if time permits. If time doesn't permit, he will be scored on the basis of whatever he was able to present. So now we will start with the competition. So our first presenter is Akshay Gupta.
He's number 2.
Yes, ma'am. Actually, there's some problem with the first two participants.
So he's just keep telling us numbers because I'm just He's number 3.
Yeah, he's number 3.
Yes, Dr. Chaudhary. Yeah, I think we should keep the track of who is presenting, right?
Yes, yes.
This is number 3, right? Yeah.
Yes.
Doctor, he's Gupta. Akash.
Akshay Gupta.
Akshay Gupta.
Okay.
Dr. Akshay Gupta, can you start sharing your screen? Ma'am, judges, we would proceed with the next participant.
Am I audible?
Yes, sir.
Good evening, everyone. I am Dr. Bharat, and I'll be presenting. Wait a minute, please. So I'm Dr. Bharat, and I'll be presenting my research on the topic efficacy of different itraconazole regimens in recurrent tinea corporis and tinea cruris, which are the subtypes of dermatophytosis, which is a fungal infection of the skin, and these are 2 most common subtypes. And this is the classic lesion ringworm as we know it. Recurrence is one of the chief problems that's going on. right now, and it's the recurrence of lesions within 6 weeks after the completion of treatment and after the therapeutic cure has been achieved. So as a result of which there is increased prevalence. Every fourth person has it in world right now, this dermatophytosis, and there is somehow this is pointing towards the resistance to the already existing antifungal regimens. And so the standard itraconazole regimen for tinea corporis and cruris, it is 200 milligrams orally for 2 weeks. So our objective was to compare different regimes of itraconazole for the treatment of such recurrent cases of tinea. So this study that we did was prospective, randomized, parallel, open-label comparative study with 40 patients that we took of such cases in PGIMS Rohtak, and prior institutional ethics committee approval was taken, and these were the inclusion criteria. So we left everything that did not justify the criteria of recurrence, that if it was more than 6 weeks, if they had any concomitant disease, any concomitant skin disease going on, any pregnant females, they were not included in the study. So these were the arms. Now this group B is the standard regime that's going on. We have compared it with group A, which is twice the dose, and group C is twice the duration, that is 4 weeks. So these are the three regimes that we've compared. So let's see which does better. So starting with the outcome measures, we saw that the outcome measures physician assessment 4-point scale, that is the symptom score, that's symptom score that includes erythema, scaling, and pruritus. This was taken and changed from the baseline in the microscopic examination, that is KOH mount. This was taken as the other outcome, uh, secondary outcome. This is actually one of the strengths of our study, that we had included both these parameters, not just one. And the statistical tool that was used was cross-tabulation analysis to check the consistency of which drug regimen is decreasing the proportion of symptomatic patients on every visit with more consistency, and the effect of proportion of patients with maximum severity score, that is the score of 3, that is the severe. We took this for the cross-tabulation analysis, and KOH positivity was also the other criteria. So this is the whole table, but it will be better understood now. Please pay attention towards this chart. I'll try to explain. So these are the three regimes. As you can see, it is divided into 3 sections. So this the first regime, if this red bar, it depicts the erythema, the scale of redness. So we can see that this is not just more consistent, but it
1
also
minute
has
left.
maximum efficacy, unlike the unlike this score in cases for example, in case of the second regime, where the erythema has all of a sudden propped up in the 4th visit and then continued in the 6th visit. So this shows that it was not just more consistent in cases of improving the symptoms. And similarly, it goes with the the KOH positivity. The best rate of conversion of positivity into negativity, KOH negativity, was seen with the group A, that is twice the dosage. So this was what we inferred from the graphs, and so as a result, this pointed out towards maybe we need to increase the dosage of itraconazole than the duration. So this might even help in formulating newer guidelines, as they are really outdated. They haven't been updated for the last 2 decades. So the strength was that we used both the microscopic as well as clinical examination.
Time up.
But thanks.
Time up.
Thank you. This was the last one.
Judges, questions, please.
Is this your first original study?
Yes, ma'am.
Okay. And what was the hypothesis, right?
Ma'am, we hypothesized, the null hypothesis was taken that there is no difference in 3 of the in 3 of the treatments. Actually, ma'am, this is the interim analysis of the full study that I am yet to complete, but this is like the halfway there it has shown these results.
Did you do a sample size calculation?
Yes, sir. The keeping the COVID in mind at that point, we calculated the sample size to be around 72 for the entire study. So it is almost complete right now, but this is the half the study that I have presented. It's consists of 40 patients out of those.
From the data that you have presented, can you come to any conclusion based on 13 and 14 patients?
So far, sir, it look the twice the dosage. It looks more promising than the standard regime and the.
At best, you can say that is a trend. You are saying it is significant with a sample of 14 and 13, something like that.
Yes,
Any conclusion?
so the minimum of it was also talked about at that time that minimum of 60 patients we have to take. Yes, the trends right now, they show that this study is pointing towards the group A, that is increased dosing showing better trends. But we still, this study I would like to justify by that minimum of 12 patients we need to take per group for getting some significant results.
Hey, that is your theory or is it a statistical theory? What little I know of statistics, the smallest size is 30, not 12. Huh? But anyway, that is fine. Madam, any questions?
Yeah, I think yes, we covered that.
Achha, achha. Thank you.
Thank you, sir. Thank you.
Thank you, Bharat sir. Thank you, judges. We will continue with our next participant, Chetan Firke, sir.
He's number 4, Chetan.
He is number 5.
Okay, just keep telling us, huh?
Yeah.
Number 5. He's Bharat Pant is a 4. Okay. His name. Okay, Chetan.
Chetan Firke. Dr. Chetan Firke.
Okay.
Am I audible, Vaishnavi?
Yes, sir.
And is my screen visible?
Yes.
Yeah.
Should I start?
So it's not in slideshow mode yet.
Right now?
Not yet.
Is it visible now?
Yes, sir.
So a very good evening to all of you. I am Dr. Chetan Firke. I am a resident in pharmacology at SGS Medical College and KM Hospital. So today I will be presenting my paper on my preclinical study, which is evaluation of the effect of metformin on 2,4,6-trinitrobenzene sulfonic acid induced chronic colitis in Parkinson. So inflammatory bowel disease, it represents, it chiefly consists of ulcerative colitis and Crohn's disease, and it represents a chronic relapsing and remitting inflammatory condition of gastrointestinal tract. And according to a study, the overall estimated IBD population in India is around 1.4 million. So Crohn's disease, out of this, it affects any part of the GI tract from mouth to anus, and its pathogenesis, it chiefly involves pro-inflammatory changes within the gut wall, and there is a major role of T cells as well. So out of the current armory of agents that is available for treatment of Crohn's disease, there are still majority of patients who still don't achieve or maintain remission, so which reveals that there is a therapeutic ceiling in the management of the disease. That is why we decided to evaluate the effect of metformin, repurposed drug on 2,4,6-trinitrobenzene sulfonic acid induced chronic colitis in Parkinson. So why we chose this particular model is that it mimics Crohn's disease in humans, and by causing transmural involvement of colon wall, and the inflammation that is developed due to TNBS is characterized by Th1 cell involvement, which is also particularly seen in Crohn's disease in humans. And why we chose metformin is that because it has anti-inflammatory effect in virtue of its causing AMPK activation, which further leads to inhibition of nuclear factor kappa P, and which further causes a suppression of pro-inflammatory cytokine production like interleukin 6 and TNF alpha. Why we decided to go with mice is that because it is particularly susceptible to TNBS induced colitis, and the inflammatory pattern that is seen in this particular species is similar to that seen in Crohn's disease in humans. So our objective was to study the effect of metformin on TNBS-induced chronic colitis in biopsy mice by assessing these following variables on day 21, which are histopathological scoring, colon weight to length ratio, disease activity index, and macroscopic grading of colitis. So the material for this study, we needed 36 biopsy mice, chemicals like TNBS, ethanol, ketamine, and our study drugs, which are metformin and sulfasalazine, and sterile surgical instruments. So coming to methodology, on day 0, we induced colitis by per-rectal administration of 1.25% TNBS in 45% ethanol. And subsequently from day 1 to day 20, study drugs were administered. And on day 21, all the mice were sacrificed and the variables were assessed. So all the 36 mice were divided into 4 groups, which are normal control, disease control, positive control, and test drug. There are 6 mice in normal control and 10 mice each in disease control, positive control, and test drug group. In positive
1
control,
minute left.
sulfasalazine, and in test drug, metformin was given. So the variables that were assessed include histopathological scoring, colon weight by length ratio, disease activity index, and macroscopic grading. So disease activity index, the components include percentage weight loss, stool consistency, and blood in stool. So out of this, the greater the score, higher is the disease activity. And colon microscopic score is again graded from 0 to 5. And histopathological score includes inflammation, extent, percentage involvement, rib damage, and regeneration. So coming to the statistical analysis, colon weight by length was assessed by one-way ANOVA, and remaining variables were by Bristol-Wallis test followed by post-hoc test. So coming to result, there were significantly lower disease activity index score in positive control and test drug group as compared to the disease control. Similarly, there was a lower score of colon weight by length ratio and colon macroscopy score, as well as histopathological score in positive control and test drug group compared to disease control. This is the summary of it. Thank you.
Judges, questions, please.
Okay. No, so what do you conclude out of your study?
My conclusion is that metformin showed comparable results to sulfasalazine in reducing the inflammatory changes in this preclinical model. And these changes were mostly assessed based on the disease activity index scoring, the macroscopic score, and the histopathological grading.
Okay.
Now, what is the meaning of this, that PC and TD groups showed significantly lower weight by length ratio?
Yes, sir.
Again, you're saying there was no significant difference between PC and TD groups with respect to colon weight and length ratio?
No, sir. What I mean is that in both...
in the abstract you have sent, the first line says both the PC and TD groups showed significantly lower colon weight by length ratio.
Yes, sir.
But last line says there was no significant difference between PC and TD groups with respect to colon weight by length ratio.
Yes, sir. So what I mean by that is that in both those groups, if we compare it to the disease control in which no agents or other drugs were given other than the inducing agent, so they showed a significant lowering of this colon weight to length ratio. But if we compare both positive control group and test drug group with each other, there was no significant difference between those two groups. But in comparison to the disease control, they showed significant growth. That is what I mean.
Okay.
Yes, sir.
Thank you.
Thank you.
Thank you, Chetan sir. Thank you, judges.
Thank you.
We will proceed with the next participant, Dyuti Mittal. Dr. Dyuti Mittal.
Good evening, ma'am and sir. My topic is clinical profile of patients with autosomal dominant polycystic kidney disease. So autosomal dominant polycystic kidney disease, or ADPKD, is the most commonly inherited Mendelian kidney disorder. And it is characterized by markedly enlarged kidneys with extensive cyst formation, which eventually leads to reduced kidney function. The incidence of ADPKD worldwide is roughly about 12.5 million, and in India there is very little data pertaining to the same. One single study 6% of the population. It has a relatively high mortality rate in patients with kidney disease, and it is 3.2-fold higher when compared to the normal population. So our objective of this study was to assess the clinical profile of the patients with ADPKD to assess the renal as well as the extrarenal manifestations. We conducted this study over 18 months, and it was a cross-sectional observational study with the inclusion criteria of patients being more than 18 years presenting to the medicine or nephrology, OPD and IPD, and they were included if they satisfied the Ravine's criteria. Ravine's criteria in brief is the ultrasonographical criteria for diagnosing ADPKD, in which the patients less than 30 years should have at least 2 cysts in one or both kidneys. Between 30 to 59 years, 2 cysts in at least each kidney, and more than 60 years, at least 3 cysts in each kidney. This is for the ones with positive family history. Our sample size was 30 patients, and we did the clinical examination as well as investigations which were necessary after taking informed consent. The results were that in our study, we noted that it was predominantly found in the males as compared to the female, and the average age of the patients were 46 plus or minus 15 years. The maximum number of patients were between the age group of 30 to 59 years, with them being 66%, and lesser in the age group of less than 30 years, 13% patients only, and 20% patients in the age group of more than 60 years. Out of all the cases, 60% were known cases of ADPKD, whereas 40% cases were newly diagnosed. And out of these cases, 25% patients were diagnosed because they were screened, since they were the primary relatives of patients who were already admitted in the hospital with ADPKD related complications. 43.3% patients had a positive family history. The remaining 56.7% patients had no family history, and this was significant.
1 minute remaining.
Most common presenting symptoms were those of uremia, such as loss of appetite, breathlessness, abdominal pain, pedal edema, nausea, nephrolithiasis. Other positive symptoms were vomiting, burning, micturition, abdominal distension. The most of the patients, 50% of the patients presented in stage 5 CKD or ESRD, and there were just about 20% patients in stage 1. The mean age of attaining ESRD as per our study was 50 years of age. 60% of the patients were hypertensive with accelerated hypertension on presentation, and 30% had UTI. There were many extrarenal manifestations, most commonly of which was hepatic cyst. We also noted patients with seminal vesicle, berry aneurysm, pancreatic cyst, gallbladder cyst, umbilical hernia. Other notable findings were that there were 10% cases with umbilical hernia and small bowel obstruction. 43.3% cases had anemia, which was contrary to popular opinion.
Time up.
Okay.
This question, please.
Yes. Can you just tell us the conclusion of the study?
And the conclusion of the study was there was a large burden of ADPKD patients who presented directly on ESRD, or who were taken on ESRD either because they were not known or because they did not follow up on treatment. So this was, had they taken treatment, and now there are novel treatment modalities such as tolvaptan. So had that been provided to them earlier, or had they had adequate hypertension control, their CKD would not have progressed. And other than that, although there were known family cases, there was very little education amongst the family members as to get screened early on and to maintain BP, or to follow up with the doctors regularly so as to avoid end-stage renal disease and the complications associated with it.
See, in your, is the disease manifestation will change as per the age criteria?
Ma'am, there was no specific change that we noted because even in the younger population, there was a significantly large number that presented on ESRD. Definitely, it will change because if the disease does progress, the kidney size does decrease or the cyst volume increases with age. But as such, we did not notice something very significant because there was a good number of patients who presented with ESRD in the younger age group as well.
Okay.
So would you like to ask something?
So what preventive measures can you suggest?
So we did offer tolvaptan to 5 of the patients who fitted the criteria as per the Mayo guidelines, and we are following them up currently. Other than that, mainly we have told them BP management for the ones who cannot be offered tolvaptan to prevent the further progression of the disease, sir.
Okay. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, judges. Thank you, Jyoti. We would proceed with our next participant, Pavandeep Kaur Sabharwal.
Is number?
Pavandeep Kaur Sabharwal
Is number 7?
ma'am, she is 8. Pavandeep Kaur Sabharwal. And
Okay.
Jyoti Mittal ma'am is
Duty Mittal is number
6.
6. So 7 is missing.
Yeah.
Okay.
Just a minute, what is the name?
Duty. This is
Huh?
Pavandeep.
Yes. Right.
Pavan.
Is my screen visible and am I audible?
Yes, you
You are audible.
Yes.
Okay. Good evening to one and all. My topic is immediate effect of proprioceptive neuromuscular facilitation on chest mobility, pain, range of motion of the thorax in patients with intercostal drainage. So when an ICD is inserted,
Your
there
PPT
is an
isn't visible, I think.
Just a minute, Pavandeep, your PPT.
And now it is visible.
Yes.
So due to the intercostal drainage insertion, there is an intercostal muscle strain which can lead to pain and muscle guarding, which can affect pulmonary ventilation in the patients. And to maintain an optimal length of the muscle, we give flexibility exercises. So one of the techniques is a proprioceptive neuromuscular facilitation technique, which targets the nerve receptors of the muscle to extend its length. So by doing this, we can improve the compliance of the lung as well as improve the ventilation, thereby reducing potential complication and reducing perioperative stress response. The aim of my study is to evaluate the immediate effect of PNF on chest mobility, pain, and range of motion of the thoracic spine in patients with intercostal drainage. So objectively, I've measured first pain using the VAS score, then measured chest expansion at rib 2, rib 4, and rib 6 levels by using measuring tape. Then I'll measure thoracic range of motion, that is flexion and rotation, by using the inclinometer and universal goniometer, and then tested the immediate effect of the PNF technique on these 3 parameters. Now, it was an interventional study. A randomized controlled trial was conducted, and sampling was done by convenient sampling in a hospital setting. So, inclusion criteria was patients who had an ICD insertion due to disease pathology and pain more than 4 on 10 on VAS were taken. Patients who had unstable vitals or trauma to the ribcage were excluded from the study. The sample size was 30 and it was calculated using Cochrane's formula. Now, after taking the institution's ethics committee approval, the recruited patients were randomly allocated to 2 groups, study group and control group, by simple random sampling. Now, after that, we first do the basic assessment of BP, RR, and PR, and then chest expansion, pain, and range of motion was measured. This is a consort chart which shows that 35 subjects were eligible for the study, but 5 were excluded because 3 couldn't meet the inclusion criteria, and 2 declined to participate in the study. So 30 samples were taken and 15 they were divided into 2 groups. After screening and after the assessment, the treatment that was given in the 2 groups are: study group received TNF and chest mobility exercises, and the control group received only chest mobility exercises. So the procedure for the intervention in the control group was 2 exercises were given, that was chest mobility exercises of chest expansion and trunk slide flexion in the sitting position. Pre and post assessment was done. In the intervention group, TNF stretches and chest mobility exercises were given. So in TNF stretches, for first technique was a hold relax technique. It was given for the trunk flexors, where the patient was asked to hold the position for 10 seconds and give and relax. The rhythmic initiation technique was given for trunk rotators, where isometric contraction of agonist was followed by isometric contraction of antagonist. And intercostal stretch was given to the intercostal muscles by applying a pressure to the upper border of the rib and in the downward direction to widen the intercostal space above it. So each stretch was given for 30 seconds with a rest period of 10 seconds. Now, statistical analysis for range and chest expansion was done using the paired and unpaired t-test. And as you can see in the table, the p-value was less than 0.001, which indicates that there was a significant difference in the pre and the post assessment. These are the graphs. Then for the pain analysis, Wilcoxon rank test and Mann-Whitney test was used. Again, the p-value was less than 0.001, which indicates that there was symmetrical distribution in both the groups, and also there was significant difference in pain. Based on this, I can say that there was a reduction in pain due to the analgesic effect with the pain gate control mechanism. Also, as we were using isometric contraction followed by relaxation, we were able to achieve improvement in chest expansion and range of motion. Limitation of my study was that since it was an immediate effect study, we couldn't assess how much duration the effect could last. Also, we couldn't compare the structure and the functional components, so we couldn't cover all the components. Clinical implication is that this technique can be used as an adjunct to the conventional technique, which is used for improving exercise tolerance in patients with ICD.
Timer.
I would conclude by saying that.
Timer. Thank you. Judges, questions, please. Yeah.
So this particular intervention, pain reduction, right? How long it will go?
Ma'am, usually TNF is given for a set of 3 sets are given. Each stretch is given for 30 seconds, and then a rest period of 10 seconds is given. So complete session will comprise of 30 minutes. So along with the chest mobility exercises, we are giving TNF stretching also.
Okay. So you feel it is more effective in terms of the acute reduction of the pain?
Yes, ma'am.
Yeah.
Yeah, because we are creating an analgesic effect. So because of which there is, due to the pain, the fibers of unmyelinated C fibers and small myelinated A delta fibers are targeted. So they inhibit pain, and hence the patient's compliance to exercises improves.
Your sample of 30, you say
Yes, sir.
they were randomly allocated.
Yes, sir.
How were they allocated?
Sir, computer generated chart was used. So accordingly, as an odd even was used, and then accordingly we divided them. 1:1.
No, 1:1. How? You see, randomly means you have chits 1 and 2, and each patient is told to pick up the chit. Then
yes, sir.
it's very unlikely that it will be equal. It seems you must have alternately, one patient you must have put in the experiment.
No.
See, random allocation is very unlikely to be equal. Your thing is exactly equal, 15-15. You can check. You see, random allocation means every person, the first person, he can be given 2 chits, one written one, and he picks up one. And it's done that way. So the chances that the 2 groups will be equal are very, very remote. When you are presenting, either do it actually or say that you are consecutively allocated or something like that. But anyway, thank you.
Thank you.
Thank you, sir.
Thank you, judges. Thank you, Purvi. We would have a next participant. Harshita Havaldar.
Oh, yes. Antidepressant.
She is the 7th number.
Yes.
7th, right?
Yeah.
Vaishnavi, is my slide visible?
It is half.
Yeah.
Okay, ma'am. I'll give me 1 minute. I'll just.
Okay.
Ma'am, it's still visible half. Now it's full. You can put it, yeah. It's not instruction, it will start.
Hello, am I visible?
Yeah, you are visible and you're audible.
Okay, thank you. Good evening, everyone. This is my preclinical study titled Antidepressant Effect of Potassium Clavulate through Enhancement of Neuroplasticity in Learned Helplessness Model of C57BL6N mice. Slides are not moving. Okay, coming to introduction, major depressive disorder is a psychiatric disorder with severe morbidity and loss of productivity. Symptoms include low mood, anhedonia, insomnia, cognitive blunting, and psychosomatic symptoms. Treatment modalities are cognitive behavioral therapy and antidepressant pharmacotherapy. So limitations of current therapy includes exact etiological basis of depression is still not known, leading to variable efficacy of the drugs. SSRI is the current treatment with SSRI leads to sexual dysfunction and decreased libido, and tricyclic antidepressants have many off-target effects, and none of the drugs are curative, and recurrence is most common. So hence there is a need for development of new drug or repurposing of old drug. The rationale for choosing potassium clavulate is it is a beta-lactamase inhibitor with no therapeutic antimicrobial effect of its own. It easily crosses the blood-brain barrier. The plasma to CSF ratio is 0.25, and as per Diog et al. Study, it has shown an anxiolytic effect in rodents by unknown mechanism of action. Also, in vitro study showed that there is a release of dopamine from neurons in the same. So we have chosen this drug to study potential antidepressant effect of potassium clavulate. The animal model which I've chosen is learned helplessness model, which is previously validated by Chaubarji et al. And it has excellent predictive validity, good face and construct validity. It is the best model to study the factors affecting etiology of depression, which is conjunction with our objectives. So my objective is to observe the effect of clavulate on brain BDNF levels analyzed through Western blot technique, and to observe the effect of clavulate on battery of behavioral tests assessing the potential antidepressant effect. So materials required are 72 male C57BL6N mice aged 8 to 12 weeks. Drugs I'm taking imipramine as positive control and potassium clavulate as test drug. Tools, Western blot analysis to assess the BDNF levels, and behavioral test, battery of test to measure the symptoms of MDD. The picture shown is a shuttle box with the 2 chamber with C57BL6N mice with electric grid at the floor. List of behavioral tests which I'll be conducting is to assess despair component of depression. I'll be taking tail suspension test with variables as immobility time across 5 minutes, and I'm taking anxiety component. Then I'll be checking using I have checked using the elevated plus maze, then duration in the center, also time span closed and closed arm.
1 minute left.
Motor agitation checked by open field test. assessment of total distance traveled during 5 minutes. So regulation, IEC permission was taken. Methodology is animals are acclimatized for 2 minutes, and then inescapable food shock is given for 1 and 2 days. And then from 3rd day, we are assessing the behavioral test. And on 10th day, we'll be taking the sacrifice sample of the brain. So endpoint will be induction. For endpoint for the induction is complete failure of animals to move despite 10 seconds. This is the study methodology. 1 to 3 days is induction, day 5 and day 7 behavioral test, and daytime sacrificing the animals. This is the Western blot result. Western blot analysis of brain homogenate revealed the presence of BDNF of 14 kilodalton, indicating the synaptic neuroplasticity. You can see the DACO antibody.
Time up.
Okay. Can you just tell us conclusion?
Yes, ma'am. My Western blot analysis of brain homogenate indicated that the presence of 14 kilodalton range of band, which indicates that the test of potassium clavulate is, and also behavioral test indicated that it is comparable with the positive control imipramine for the anxiety and psychomotor evaluation of component of depression.
Archit, a good study, but I have objection to one slide. You said that antidepressants do not cure depression. Now, you're a pharmacology student, you know.
Yes, sir.
How many, apart you really leave aside the antibiotics, how many other medications are curative? The argument is wrong. You see, any cardiovascular medicine is not curative.
Yes, sir. But the recurrence and recurrence.
That is the nature of the disease.
Yes, sir.
It is the nature of the disease, not the fault of the medication.
Yes, sir.
But anyway, well done. I have no question. Madam, any questions?
Yeah, I also do not have any question, right? But it is with the BDNF level, right? The neuroplasticity indicating the rise in BDNF levels.
Yes, ma'am. My primary objective was to check the neuroplasticity in the hippocampus to see the neuroplasticity. So I checked the mature BDNF levels, and for the behavioral assessment, I've done the battery of tests, that is elevated plus maze and tail suspension.
Yeah, I just have a one question. What is what is the advantage of knowing neuroplasticity in humans? Why do we should know about neuroplasticity?
Ma'am, there are actually many theories of depression, such as 5-HT and dopamine, and the other consecutive IL-6 and IL-8 components, which there is no, most of the theories, they have targeting only 5-HT and dopamine, the available drugs. So I wanted to check neuroplasticity and the effect of potassium clavulate on neuroplasticity.
No, neuroplasticity. Okay. Neuroplasticity is a big concept, right? And its advantage in the human in terms of the mental illness or the brain, that's the reason why it is so being followed, now.
Yes, ma'am. The new theory, which is regarding neuroplasticity, depression is linked to neuroplasticity in the hippocampus, ma'am. The newer theory which we are discussing, and also my limitation of the study is that I couldn't isolate just the hippocampus. I had to take the whole brain homogenate for my study, ma'am. The limitations in that.
Okay.
Thank you, ma'am.
Thank you, Douglas. Thank you, Archita.
Thank you.
Proceed with our next participant, Vidya Ramanathan.
He's number 9. Vaishnavi?
Ma'am, I'll let you know. Just...
Vidya.
Good evening, ma'am and sir.
Vidya Ramanathan, ma'am, is number 9.
Good evening, everyone. I'm here to present my paper on assessment of fetal-maternal outcome in planned versus emergency cesarean section in a tertiary care center. Cesarean section is defined as the procedure of delivery of the fetus by an incision in the abdominal wall, followed by an incision on the uterine wall. It is one of the most commonly performed obstetrical procedures today, with an incidence of about 20 to 25%. The most frequent indications include fetal distress, dystocia, failure of labor to progress, cephalopelvic disproportion, previous cesarean delivery, breech presentation, and maternal requests. The complications of cesarean section are observed more commonly in emergency than in planned sections. Perinatal mortality rates have gradually decreased, but complication rates remain higher in emergency than in planned cesarean sections. The aim of our study was to assess the fetal-maternal outcome in planned versus emergency LSCS. The objective was to find out the different incidence of indications for both the groups, to assess the maternal outcome in terms of preoperative, intraoperative, and postoperative complications, and to assess the neonatal outcome in terms of Apgar score at birth, NICU admission, and perinatal mortality. It was a prospective comparative study conducted in the Department of Obstetrics and Gynecology over a period of 1 year in 600 pregnant patients undergoing LSCS. 300 of them underwent elective LSCS and 300 of them underwent emergency LSCS. My inclusion criteria were all pregnant women of any age group with a singleton pregnancy with a gestational age of about 34 weeks undergoing cesarean section for any indication. Multiple pregnancies were excluded from the study. Ethical clearance was taken. Written informed consent was taken, and details regarding the indication, the complications during the intra-op and post-op period, and maternal and neonatal morbidity and mortality was collected. Coming to the results, the various incidents of various indications for planned and emergency LSCS was calculated. The type of anesthesia used for both of them. The intra-op findings, that is whether uterine closure was done by single or double layer, and whether or not extra sutures such as B-Lynch or Chow sutures, which are required in case of atonic PPH, were to be taken. The incidence of postpartum hemorrhage in both the cases, and the incidence of requirement of ICU admission for the mother, and incidence of maternal mortality. The outcome of the baby, whether the baby cried immediately or required some form of resuscitation, whether the baby required NICU admission, and the rates of perinatal mortality. The most common indication for emergency LSCS was fetal distress, followed by non-progressive labor and failure of induction, whereas the most common indication for elective LSCS was previous cesarean section, followed by cephalopelvic disproportion. Overall, the most common indication for LSCS was previous cesarean section. A study conducted by Lakshmi et al. Also showed similar indications, as repeat cesarean being the most common indication, followed by CPD. While a study done by Cheheria reported that most common indication was previous LSCS in both emergency and planned LSCS group.
1 minute left.
In comparison of anesthesia, more cases of emergency LSCS required GA, and overall intraoperative complications of atonic PPH were found more in emergency LSCS, which is why they required blood transfusion and also more requirement of Chow and B-Lynch sutures. More cases of emergency LSCS required ICU management, and 2 patients out of the 15 ICU admissions ended up being cases of maternal mortality. No mortality was observed in planned section. 33% of babies born via emergency LSCS required some amount of resuscitative measures such as stimulation, positive pressure ventilation, or intubation, and only 6% needed them in planned LSCS. NICU admission was also more in emergency LSCS. Perinatal mortality was observed in only 2 cases of emergency cesarean group, and no case of elective cesarean had any case of perinatal mortality. So since history, the indication of cesarean sections have been changing. In our study, emergency cesareans have shown significantly higher maternal and fetal complications compared to planned cesarean sections. Early pregnancy registration and thereby screening of high-risk patients may significantly reduce the incidence. Thank you.
Okay, so what are you suggesting, Vidya? For this, especially in emergency cesarean, how to be done? Okay, in fact, they are done basically on that purpose. We probably will not have reduction in emergency cesareans. But what are you trying to suggest here?
Yes, ma'am. I mean that would be one of the limitations of my study, that certain indications of obstetrics will be an emergency section that cannot change. Like things like fetal distress cannot happen in an elective manner. But ma'am, certain indications such as previous cesarean sections or placenta previa or breech presentations or cephalopelvic disproportions that can be detected early on can be planned for elective cesarean section, so that certain complications that can be reduced. Like in case a patient comes in labor in breech, rather than that, if she can be planned for section beforehand, it would come out with better outcomes.
So that means all these, emergency cesarean can be converted into elective, right?
No, ma'am, not all of them. That's what I'm saying.
I mean, some of them, if you
some of them can be correct.
Okay. Okay.
Yes, ma'am.
Okay.
I have no question. Thank you.
Thank you, David. Thank you.
Thank you.
Vidya. We will proceed with our next participant, Dr. Sagar Sangore.
Sagar, he's 10th
Yes.
one?
Sagar Sangore. Yes, sir. Yes, ma'am. 10th.
Am I audible?
Yes, sir.
Sagar. Yes.
Okay. Very good evening, ma'am. Good afternoon. Good evening, sir. Sir, I'm going to present this case of clinical and hematological profile of patients with bicytopenia in a tertiary care hospital. It was under the guidance of Dr. Pratik sir and Dr. Kaustubh Salagre sir. So bicytopenia, as we all know, it's basically defined as any two cell lines in the blood when they are reduced. It is called as bicytopenia. Now, it is very important to study this because it is a very sensitive indicator to find out the differential diagnosis. And therefore, it helps us to find out what could be the likely cause of that particular bicytopenia. The very few studies which were done in this regard, therefore, we had decided to study this in our hospital. The objective was to find out the clinical and the laboratory profile, along with the various etiologies and the outcomes of the patients who were enrolled in hospital with bicytopenia. So it was an observational cross-sectional study. It was conducted for the period of 18 months, and it was in the medicine ward and the ICU of the KM hospital. Inclusion criteria had people who with age of 12 and more than 12 with having CBC reports as to bicytopenia or which had developed bicytopenia during the ward course. But we had excluded the patient who had received blood transfusion and later on had developed bicytopenia. Along with that, the inclusion criteria had included the people who had given us a valid informed consent. The patient with pancytopenia was definitely excluded from the study. The sample size which we calculated was around 194. But because of this COVID pandemic, we could not get as many cases. So our sample size was reduced to 110 subjects. It was very difficult to find the prevalence of this study because this was not done in many Indian population. So we had derived it from the nearest one possible from the AFMC where it was conducted recently in 2019. The analysis was done using SPSS software when we had incorporated the data in the Excel sheet, and the quantitative and qualitative data was analyzed later on using a chi-square and the Fisher exact test. So what were the results of this study? We found that the majority of the patients which we had included were male. The 70% were male. Apart from that, the maximum number of participants were belonging to the age group of 31 to 60, followed by less than age 30, and very minimal patients were in the elderly age group. As we find out that the patient having bicytopenia had maximum leukopenia with thrombocytopenia as a group, followed by anemia with thrombocytopenia, and the list patient had the anemia with leukopenia. So as we can see here that the number of cases that we found as was divided into infectious and non-infectious causes. So in infectious etiology, we found that the patient with presented with bicytopenia had dengue, plasmodium vivax, malaria, along with HIV-related bicytopenia, and AFI with undiagnosed reason for that febrile illness, having this majority of cases. In non-infectious etiology, we found out the chronic liver disease, autoimmune diseases like lupus, and some few cases of retinal poisoning were also associated with bicytopenia. Apart from that, the majority of chunk was because of the nutritional deficiencies, and vitamin B12 was one of the important factor in that. The jail, gender, and the age distribution of this infective and the non-infective etiology was almost a similar trend. It was shown as previously. So as we can see, again, the infective and the non-infective causes are overall similar in male as well as in females. In age group also, the similar
1
trend
minute left.
followed. Yeah. The maximum presentation were generalized weakness, fever, breathlessness, followed by general examination findings first of pallor edema as a predominant examination findings apart from hepatomegaly and splenomegaly. We had conducted bone marrow biopsy only for 6 patients, which has shown us lymphoma and HIV-related bicytopenia as among the other causes. The CBC report, which was followed after 3 months, had shown a very drastic improvement in the CBC report, because as we can see from the outcome that the patient maximally were discharged from the ward. Only 6 patients had this mortality rate, which was secondary to very severe infections like lymphoma and severe sepsis and all. So what we conclude is that biosector is a very common condition that we come across in hospitals. And resource limited setups like PSCs and district health center, which we do not have so many investigations available, by using this thing, we can think of which is the most likely diagnosis. So we can narrow our differential diagnosis, which can help us to find out how to treat the patient early. Also, we find out one important thing was that bone marrow biopsy is not required in most of the cases. Sample size was small, so it could have been extrapolated in further studies. Thank you so much.
So Sagar, that means this pancytopenia is more seen in cases of dengue, malaria, etc.
Yes, ma'am. Yes, infective causes were the majority of etiological factors responsible for pancytopenia.
Okay. And suppose if you, I mean, many of probably can remain untreated, right? In maybe rural side and all. So in untreated patients, what can be the outcome?
Ma'am, the outcome is overall, I mean, if the maximum reason we had found was dengue. So dengue, anyways, we have to just do the fluid therapy also and antibiotics, which have generally been practiced in PSCs also, irrespective of the diagnosis which is met. So if a patient comes to with fever, generally we give some antibiotics over there. So the overall prognosis is okay. But anyways, it tells you like to find out the rare causes of it. Like the infective causes are common, but sometimes we have lymphoma, HIV-related causes, sepsis-related causes. In that cases, it is important that we also note the other causes, so that better management can be planned.
Okay, but in cases like malaria, see, not all the people who reach to tertiary care centers or even a simple centers. So is there possibility of natural correction?
No, ma'am. I mean, we do not know, ma'am, exactly, because we had studied the patient only with pancytopenia. So we do not know for sure. We do not have the data, ma'am, for that. But yeah, we do not have data. Yeah.
Has this been studied in India before?
Yes, sir. Recently in 2019 in AFMC, it was studied, and the samples was around 200, and we had evaluated and concluded similar kind of results, that infective was the more common reasons for pancytopenia.
Okay, thank you.
Thank you, sir. Thank you, ma'am. Thank you.
Thank you, judges. Thank you, Sagar sir. We will proceed with the next participant, Dr. Sanchita Shirore.
She's number 11, Vaishnavi?
Yes, ma'am. Dr. Sanchita Shirore.
Is she there, Sanchita?
She's there in the meeting, but I don't know what the problem is. Till then, we will proceed with the, like, she is there now.
She has started, Sanchita started.
Ma'am, you are not clearly audible. And Rajashri is having some technical errors, so we would proceed with the next participant. Our next participant is Shanak Lohite.
Yeah, am I visible and I'm audible?
So you're audible.
Hello?
You are not yet visible.
Am I visible now?
Judges is so visible. It's not visible to me. Yeah, you are not visible now. So.
Okay. Okay, so good afternoon, judges. I'll get started with my case presentation. The topic of my presentation is clinical profile of patients with ocular manifestations of connective tissue disorders and outcome over 3 months follow-up. I'm the presenting author, and the principal investigator and the author is Dr. Kunal Marathe, KM, Hospital, Medicine. So rheumatological disorders are known to have ocular involvement as one of the cardinal symptoms, ranging from mild and non-specific discomfort to sight and life-threatening manifestations. More often than not, ocular complaints are neglected by the patient. That is because of two reasons. One of them is because of the concomitant severity of the systemic symptoms of the rheumatological illness. And the second one is because they are minor or ophthalmologic complaints which can be neglected by the patient. And ocular involvement, which is there, it can sometimes herald the onset of the CTD. And for this reason, the patient might be consulting an ophthalmologist first rather than going to a rheumatologist. Ocular involvement in these CTDs can also correlate with disease severity. And one more problem, which is there is a drugs which are used for treatment of these connective tissue disorders have implications in causing ocular problems. So there can be a drug-limiting side effect, ophthalmic side effect, which can be seen in these conditions. So the objective of this paper was to study the clinical profile of ocular manifestation in connective tissue disorders, to note the temporal relationship between the onset of the connective tissue disorders and the eye involvement, and to note the modalities of treatment for ocular involvement of these various CTDs. And the last one was to study the short-term outcome of eye involvement over 3 months follow-up. So the material and method which were done was a prospective observational single center study was carried out at a tertiary healthcare center, rheumatology OPD as well as IPD after IEC approval. 110 patients who were diagnosed case of some CTD. Now, these diagnosed cases were according to the diagnostic criteria of the respective connective tissue disorder, having some form of ocular involvement, either on asking the patient or the patient's own complaints were enrolled in the study. Detailed clinical history of the connective tissue disorder and its ocular involvement, along with examination of the patient, was done. Routine investigations were directed as per the discretion of the treating physician and were conducted, and the findings were noted down after the patient's consent. The patients were followed up for 3 months to note the outcome of the ocular involvement. Now, the inclusion criteria, which is an age of more than 18 years, and patients with diagnosed CTD as per the respective diagnostic criteria were included in the study, and patients willing to participate in the study were included in the study. Now, this is the results which were obtained. Now, in the results that were obtained, this first table, which is suggesting about the age distribution, the total number of patients. So, out of the total patients which were there, about 30% of the patients which were there, they were in the age group of 26 to 35 years. Is there any disturbance from this side? Actually, it's not from me. Hello.
Yes, sir.
Hello. There's a disturbance which is there. It's not from my side. So talking about the age distribution of the patient. Talking about the age distribution of the patient. About 26 to 35 years age group which was there. There were maximum
just
number
give
of
me a
patients.
minute. I'll rectify it and you can start presenting again.
Okay. Hello, can I restart?
Yes, sir. Try once again now.
Okay.
Sorry for the disturbance.
So, yeah. Looking at the age distribution of the total patients who were included in the study, about 30% of the patients belong to the 26 to 35-year age group, followed by the less than 25-year age group. And then came the 36 to 45 age group. Now, if you look at the age distribution of the individual systemic disorder which was noted in these patients, you can see the maximum number of patients which were there in the study were cases of SLE in the age group of 21 to 30 years. And the second highest number of patients included in the study were cases of rheumatoid arthritis, which peaked at the age group of 41 to 50 years. Now, this actually correlates with the natural history of the respective illness, as SLE is seen more commonly in the younger age group and RA peaks at the age of 41 to 50 years. And so the ocular involvement in disease also happens at the peak of the disease activity. And the second was the gender distribution. Now, because most of these connective tissue disorders are female preponderance, maximum number of patients in this study were females. So a female to male ratio of 6.33 to 1 was seen in the study. And among all the cases which were noted, systemic sclerosis, rheumatoid arthritis, SLE, Sjogren's, mixed connective tissue disorder, and seronegative spondyloarthropathy, all of these is female preponderance with even female preponderance in ocular involvement. But in case of seronegative spondyloarthropathy, as it is more common in case of males, even ocular involvement is more commonly noted in males. So this was about the gender distribution in the study. The next is the total number of connective tissue disease which was seen in the study. So among the total 110 patients, maximum number of SLE patients were recorded, followed by rheumatoid arthritis, which were 31 patients. Then we have Sjogren's, followed by mixed, that is primary Sjogren's, followed by mixed connective tissue disorder, systemic sclerosis, spondyloarthropathies, vasculitis, which is followed by the rarer later causes like sarcoidosis, dermatomyositis, and good passion. Only single case of these were noted in the study. Now, moving on to the eye involvement, which is found in SLE patients. The most common eye involvement was in the form of dry eye, that is keratoconjunctivitis sicca. It was seen in about 24 of the patients. The second important complication, which is important note here, is the cataract, which was in these patients, which was likely related to steroid use in these patients.
Sir,
so a
time up.
posterior subcapsular cataract.
Time up.
Fine. So, okay. Hello?
Yes, sir.
Hello?
Yes, sir. Judge this question, please.
What is the conclusion of your study?
The conclusion of my study was that ocular involvement was commonly underreported and undertreated in these CTD patients, and that was because of the less severity of the symptoms and the greater severity of the systemic complaints in the patient. And the second important thing, which is that it is keratoconjunctivitis sicca. It is because of multitude of, that was the most common known ocular manifestation. I was not able to establish any temporality between the onset of the ocular symptom and the disease onset, but on noting that these patients have these particular complaints, simple treatment modalities just like giving artificial tears and topical steroids was very effective in improving of the symptom outcome in these patients. So it is not as that ocular involvement corresponds or correlates with the disease severity in these patients. However, ocular involvement is something which has to be looked into in all CTD patients.
Anything novel in the study?
So the one important finding which I found was usually in case of SLE, in case of rheumatoid arthritis, most common ocular manifestation is found to be scleritis and episcleritis. But here, as it was noted in the study, it was more commonly associated with dry eye, keratoconjunctivitis sicca, rather than scleritis and episcleritis. And keratoconjunctivitis sicca, because of the disrupted function of the lacrimal function, it is a problem which is very easy to treat, and it can help in preventing further complications like scleromalacia perforans or corneal liquefaction and other problems.
Okay. Ma'am, any questions? Vaishnavi, no more questions from my side.
Okay, sir. Thank you, sir. Thank you, judges. Thank you, Shanak. We would have a next participant, Shreya Rati.
background change
Good evening, everyone. Am I audible and visible?
Yes, ma'am, you are audible.
Good evening, respected judges and fellow colleagues. I'll be presenting my paper on assessment of quality of life in vitiligo patients in terms of clinical severity and psychological burden in a tertiary care hospital, an observational study.
Ma'am, the PPT is not yet in slideshow mode.
Is it not? me a minute. Is it in slideshow mode now?
Not yet, ma'am. It's in slideshow mode now. You can start.
Vitiligo is an acquired primary progressive melanocytopenia with unknown etiology, histopathologically characterized by the absence of melanocytes in the involved skin. It is a psychologically devastating condition, especially in darker individuals because of chronic nature of the disease, lack of uniform effective therapy, and unpredictable course of the disease. WHO defines quality of life as an individual's perception of their position in life in the context of culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. It is important to acknowledge the psychological components of the disease, and appropriate treatment will enhance the quality of life in vitiligo patients. My objective
Ma'am, the picture is not moving.
My objective was to assess the quality of life in vitiligo patients in terms of clinical severity using the VASI score, psychological burden using the VIS 22 questionnaire, and dermatology life quality index using the DLQI score at a tertiary care hospital. A prospective observational study on 60 patients with age of more than 16 years was conducted over a period of 4 months on OPD basis. Informed written consent was taken and demographic details were noted. The clinical severity, psychological burden, quality of life of patients was assessed using the VASI, VIS 22, and DLQI respectively. VASI score was calculated using the formula summation of hand units at all body sites multiplied by residual depigmentation. VIS 22, a disease modified version of VIS, that is vitiligo impact score, was consists of 22 easily comprehensible questions, 19 common to all, and one for each married, unmarried, working, and studying. The interpretation was as follows: 0 to 22 were mild psychological burden, 23 to 44 moderate psychological burden, and 45 to 66 was a severe psychological burden. Dermatology life quality index includes 10 items on patients' symptoms, feelings, routine activities, kind of clothes, social or leisure activities, physical exercise, educational activities, sexual activities, and interpersonal relations with a score of 0 to 30. 0 to 1, interpretation of 0 to 1 was no or minimal impaired quality of life, 2 to 5 was mildly impaired, 6 to 10 moderately impaired, 11 to 20 largely impaired, and 21 to 30 was extremely impaired quality of life. My results were as follows. Mean age was 35.27 years with a standard deviation of 2.24, in which 53% were males and 46.7% females. The marital status, 51.7% of my patients were married. 30 on occupational basis, 30% were students and 23% housewife. My results for my mean VASI score was 4.11, VIS 22 was 37.32, and DLQI was 11.73. There was a statistically significant association between the VASI, DLQI, and VIS 22 score as seen in the table. Most of my patients had a VASI score of 2.0124 and largely impaired psychological burden and largely impaired quality of life and greatly impaired psychological burden. My strengths were that the hidden psychological burden along with clinical severity could be assessed. Early commencement of counseling and treatment could help in enhancing the quality of life. My limitations were limited period of time, sample size, and inability of the patients to get investigated for biochemical or serological abnormalities found the limitations.
Time up.
Good presentation. Good presentation, Shreya. But
Thank you, sir.
can you tell me why you use the DLQI?
So I basically wanted to know the quality of life. So dermatology quality of life is very specific to dermatological conditions.
No, but dermatology conditions though vary from very small to very large. Nowadays, the trend is to have specific scales. No, there is a vitiligo life quality index or something like that.
Yes, sir.
Made for vitiligo, and that has been made long time back. That would be preferred, rather than use a general scale. The dermatological life quality is all skin diseases, but the vitiligo scale would have been better.
Yes.
No questions from my side.
Yeah.
Madam?
I have a question, Shreya. For just to improve quality of life, you would like the patient to be referred to a psychiatrist?
Yes, ma'am, definitely.
I mean,
I would
what is that psychiatrist would do which you won't be able to do?
A proper counseling of the patient as to how normal a vitiligo is as a disease and how to live with it and cope up with negative influences from others and cope up with their normal routine activities as well as excel in most of the activities that they would like to do.
Yeah, but that even skin specialist can do, right? I mean, why would a psychiatrist would talk about vitiligo and how common and how is that not something skin specialists should do? I mean, contribute into the improving of the quality of life of their patient.
Yes.
Yeah.
Yes.
Right. I finished.
Thank you, Shreya. We would have our next participant, Shreyas Milmile.
Next is Sagar Sangole.
Shreya Rathi, can you stop presenting?
Yeah. Next is who?
Shreyas Milmile.
Shreyash, okay. 14th.
Yes,
Yes, ma'am.
Hello, am I audible?
Yes, sir.
Yes.
Yes. Just 1 minute. Is my PPT visible?
Not yet, sir.
Now?
No, sir.
Not yet.
So you may click on the share screen option and share the entire screen and again try.
Okay, I'll try again.
Yeah.
Hello.
The PPT is visible.
Is the PPT visible?
Yes, sir.
Good evening, everyone. Am I audible?
Yes, sir.
So I am presenting a paper
Yes.
on the serum zinc levels and its association with severity and complications in liver cirrhosis. This is an analytical cross-sectional study. I am Dr. Shreyas Milmile, the presenting author, and my co-author is my guide, Dr. Shirpurkar. So in introduction, liver cirrhosis has become a global health problem in the last 2 decades. We all know that the most common causes of cirrhosis have been alcoholic abuse and viral hepatitis. And the burden due to the death burden due to cirrhosis globally has also been up to 2 to 3%. So liver cirrhosis is defined as anatomical diffuse process with fibrosis and nodule formation. Also, it is associated with multiple complications like hepatic encephalopathy, upper GI bleeding, jaundice, ascites. Serum zinc levels have been found to be deficient in many patients of liver cirrhosis, and it has been due to various factors like inadequate intake, diminished hepatic extraction, and impaired absorption. Many of the features of liver cirrhosis have also been linked to zinc deficiency, like loss of body hair, testicular, cerebral dysfunction, etc. So zinc also plays an important role in enzymatic reactions responsible for converting ammonia to urea via adenosine transcarbamylase in the liver. Poor zinc status has resulted in the impairment of nitrogen metabolism as well. So the rationale behind my study is that despite the existence of many published literatures, screening for zinc deficiency in cirrhosis has not yet found its way in standard management. Like early screening, when the patient is diagnosed with cirrhosis, serum zinc levels have usually not been looked for. So the aims of my study are to determine the association of serum zinc levels and complications of liver cirrhosis, and also to study the association between serum zinc levels with the severity of liver disease, which I had assessed by using the Child-Pugh and MELD score. So the materials and methods, I have taken the institutional committee approval and written an informed consent was taken from all the patients, and they were screened. Once the patient was diagnosed with cirrhosis, they were screened for all the complications, and severity was graded according to CPT and MELD score. Sample size, so this is a hospital-based study in which consecutive patients admitted in medicine ward were chosen, and as per this formula, the sample size was 78. So I have collected sample size of 100 patients. It was an analytical cross-sectional study, and the inclusion criteria was age more than 18 years and patients showing signs and symptoms of cirrhosis, along with diagnosis of liver cirrhosis on a USG. So these are my results. In the results, most of my patients were aged between 30 to 40, and almost more than 90% of the patients were males. There were only 8 female patients. So in the 100 patients, serum zinc levels were found to be less than 52 in 66% of the yes. And these are the association of serum zinc deficiency with the complications. As you can see, all the multiple complications of liver cirrhosis, almost every patient had almost 60 to 70% of the patients had zinc deficiency. In the Child-Pugh score, as you can see, the Child-Pugh B and C, most of the patients were Child-Pugh B and C, and most of them had liver deficiency of zinc. And similarly for the MELD score, the patients who had a MELD score of more than 16 had zinc deficiency up to 77%. Also, I had association of zinc deficiency with the clinical approval, whether the patient was discharged or whether the patient died. As you can see, the 24 patients which died, in them 20 of them had zinc deficiency. So we came to the conclusion that zinc deficiency was also associated with increased mortality. My study showed that there was a high prevalence.
Complete your conclusions.
Yes, ma'am. These are the conclusions that there was 67% prevalence of zinc deficiency in cirrhosis. Among that, the patients who had more severe liver disease, with B and Child-Pugh B and C had more. The deficiency was higher, and also patients who had zinc deficiency had increased mortality.
So, what will be your recommendation?
So the recommendation is that if we diagnose a patient of cirrhosis, it is imperative that we can do early serum zinc, and we can give supplementation to the patient, as serum and zinc supplementation is very cheap, and then which will help in preventing the complications and mortality due to serum zinc deficiency. So I am also doing one study in which I am assessing whether zinc supplementation is beneficial or not. That is ongoing.
Okay. And most of your patients are alcohol, right?
Yes, ma'am. Actually, in my study, the inclusion criteria is that patients should have cirrhosis. irrespective of the etiology. But yes, most of the patients were alcoholic.
Okay, so in that sense, what would you suggest? Do you have any recommendation? When you think about zinc in these patients, because alcohol is a big problem.
Yes.
In the country, right?
Yes. Because the problem is for alcoholic cirrhosis, obviously the more important thing would be that patients give up alcohol, stop alcohol, have alcohol abstinence. Only then we can supplement. Only then zinc supplementation might help them.
Okay,
Hello.
Okay,
Yes.
I finished asking. Yes.
One question only. Your cross-sectional study, isn't it?
Yes, sir.
So cause-effect relationship, can you make?
Cause and effect. Yes, sir. Actually, initially it was that what the reason which is causing the deficiency was assessed, but then I talked to statistician, and the studies which have been done earlier, on basis of which I have decided. So they said that don't look for the cause. We have to just go with the diagnosis and then see what further complications, and we have to assess at that point.
No, even that, you see, correlating zinc with a complication.
Yes.
Should be done with a longitudinal study. A cross-sectional study says these are both present. The cause effect that the zinc deficiency is causing the complication, you cannot conclude on the basis of a cross-sectional study. You need a longitudinal study for that.
Okay, sir.
Again to the statistician.
Yes, because I talked to them, so they told me to do this study in this manner.
No, that is fine. That's fine. You see, the finding is there.
Yes.
Complication and it is correlated with zinc.
Yes.
But cause effect you cannot say. You're not supposed to say on the basis of cross.
On the basis of.
Okay. That's all. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, judges. We would proceed with the next participant, Shruti Shetty.
Shruti Shetty.
Shruti Shetty.
Can you hear me?
Yes, you are audible.
Shall I start?
Yes.
Yeah, you can start.
Good evening, ma'am and sir. My topic for today is correlation between fetal middle cerebral artery and umbilical artery Doppler ratio at 38 to 40 weeks of gestation with fetal distress and adverse perinatal outcome. Fetal hypoxia is one of the major causes of high perinatal mortality and morbidity. Use of Doppler ultrasonography can give us an access to the fetal circulation. So the integration of low velocity waveform of middle cerebral artery, umbilical artery obtained from color Doppler will help us know the cause of fetal hypoxia. And knowing this modifiable risk factor causing fetal distress is of great importance determining the optimum time and mode of delivery and thus improving the perinatal outcome. CP ratio calculated as a ratio of MC to uterine artery has been hypothesized to be more accurate than its components. So in our study, we compare the prognostic accuracy of CU ratio, MCA Doppler and umbilical artery in prediction of adverse perinatal outcome. Is a diagrammatic representation of the Doppler waveforms. Our aim of the study is a correlation between fetal middle cerebral artery, umbilical artery Doppler ratio with fetal distress 30 to 40 weeks. Our objective is to determine the CU ratio in patients at gestation of 38 to 40 weeks to determine the relationship between fetal middle cerebral artery and umbilical artery Doppler ratio with fetal distress at 38 to 40 and to know if this ratio is a better predictor for an adverse perinatal outcome. This was an observational study, prospective observational study in a tertiary care hospital done over a period of 1 year. We included 100 pregnant patients between 30 to 40 weeks of gestation age with no complication. Written informed consent was taken. They were subjected to Doppler ultrasonography, and all indices such as middle cerebral artery, umbilical artery, and CU ratio were noted. These patients were then further on, we were seeing the maternal outcomes such as NST, mode of delivery, fetal outcomes such as MSL, fetal distress, intermittent growth retardation, and perinatal death, and other neonatal outcomes such as Apgar score less than 7 at 5 minutes, and NICU admission, acidosis on blood gas, birth weight less than 10 percentile, need for resuscitation at birth, are variables which were quantitative were analyzed using an independent t-test, and are variables which were qualitative were analyzed using a chi-square test. In our study, we had 60% of primary gravida, 40% of multigravida, out of which 83% had reactive NST, 17 had non-reactive NST. The mean of middle cerebral artery was 1.38. The mean of umbilical artery PI was 1.04 and CU ratio was 1.43. Now we had 40 LSCS and 60 normal deliveries. Out of the normal deliveries, 24 delivered spontaneously, 36 were induced, 24 were less than 10 percentile birth weight, and 76 were more than 10 percentile. NICU requirement was for only 30% of the cases. Now, association of CU ratio with the outcomes. Now, 40 patients which were taken up for taken for LSCs, the mean PI was 1.26, and for normal delivery was 1.55. The ones whose Apgar score was less than 7 was 0.76, more than 7 was 1.46. Ones which required an ICU admission was 1.09. And now there's a linear relation between the birth weight and post-delivery cord pH with the CU ratio. Now, there's a very important table in which we are going to
1 minute remaining.
Proceed.
1 minute remaining. Okay, this is a very important table showing a comparative study between the adverse outcome and the Doppler findings. As you can see, the MCI PI is decreased in 50% of the cases. The uterine artery PI is increased in 60%, and the CU ratio is decreased in 28%. Now, this is very important. Now, the MCI PI, now, as you can see in all three values, the sensitivity is more in CU ratio is 82, specificity is 78. So our CU ratio is more specific, so its diagnostic accuracy is also 80%. Conclusion, cerebrovascular ratio gives us an information about both placental insufficiency as well as fetal response to the resulting hypoxia. Therefore, it can be said that the cerebroplacental ratio is a better predictor for fetal distress and adverse perinatal outcome than the individual pulsatile index of the middle cerebral artery and umbilical artery taken alone. Hence, although the sensitivity of cerebroplacental ratio and umbilical artery PI are comparable, the specificity of cerebroplacental ratio is higher than that of umbilical artery PI. Thank you.
Okay, sir can ask the question.
This finding of yours, is it in the literature or is it something novel?
Sir, this finding is there in literature as well, but we do not routinely calculate the CU ratio. Actually, we only see the umbilical artery PI, and according to that, we always and most commonly we do Doppler only for patients of PIH or preeclampsia who we suspect that there will be some Doppler changes. We send them. Specifically for our study, we have the 100 cases that we had taken up which had no complication at all. In them, we had done a Doppler.
Okay.
Yes, sir.
That's all from me.
Thank you, sir. Thank you, ma'am.
Ma'am, you would like to ask some questions, or should we proceed with the next?
She can.
So, thank you, Shruti. We will proceed with the next participant. Our next participant is Abhishek Jha.
Abhishek?
Yeah, ma'am, the first participant.
Okay. Abhishek, what is his surname?
Abhishek Jha. Ma'am, he must be there in the sequence itself. I had modified it earlier.
I can see that, yes.
Yeah. Dr. Abhishek Jha.
Yeah, hello, can you hear me?
Yes.
Yes, sir.
Okay. Is my screen visible?
No.
Not now.
No.
Not yet.
Just 1 second. Hello, is it visible now?
Yeah, it's visible, but it's not in yet in slideshow mode.
Just 1 second.
Down there's a button where you zoom in and zoom out. Besides that,
Yeah.
next is
Start. Hello, can I start?
Yes,
Yes.
please.
Good evening, ma'am and sir. My topic for the paper is a correlation of serum albumin levels in acute ischemic stroke patients. The study was conducted in MGM Hospital, Kamote, medicine department, the ward as well as the ICU. Introduction. Stroke or cerebrovascular accident is a global life-threatening neurological disorder. It constitutes more than 50% of hospital admissions in a year. The etiology of ischemic stroke is due to either a thrombotic or embolic event that causes a decrease in blood flow to the brain. Brain ischemia can frequently be triggered through the lack of global brain blood supply in more proximal causes of hemodynamic dysfunction causing sudden blood pressure fall. Albumin is a multifunctional protein which has been proven to have neuroprotective effects in animal studies. Albumin therapy is capable of minimizing infarction volume and cerebral edema. Albumin reduces hematocrit as well as erythrocyte sedimentation rate by its effects on erythrocyte aggregation. Effect of albumin is mainly in the early reperfusion phase of acute ischemic stroke, where it exerts an inhibitory effect on stagnation, thrombosis, and leukocyte adhesion in microcirculation. Objective is to determine the correlation between serum albumin level and acute ischemic stroke. It is taken as the stroke severity is taken with the help of NIH's scale. The materials used were the CT and MRI machines as well as the laboratory instruments. Methods. A prospective observational study was conducted under the Department of Medicine, MGM Medical College and Hospital. A written signed informed consent was taken from all the patients prior to the enrollment in the study. A total of 75 patients were admitted with diagnosis of acute ischemic stroke and meeting the inclusion as well as the exclusion criteria. The criteria being patients diagnosed with acute ischemic stroke on either CT or MRI scan, and patients falling in the age group of 25 to 70 years, and patients were included from either gender. The exclusion criteria were patients were present after 24 hours of onset of symptoms, patients having previous history of stroke, patients obviously having hemorrhagic stroke on presentation, patients having a stroke due to other causes like subarachnoid hemorrhage. These were the results which I'm going to speak about. In the presence, in the study that was done, it was observed that the mean age of the study population was 52 plus 13 years, which was the standard deviation. Almost 58.6% of the cases belong to the age group of 51 to 70 years, which is in the 6th and 7th decade of life. There was a very strong male preponderance in the study population itself. That was out of the 75 cases we had taken, 65 were found to be male and 10 were female. The age distribution was similar in both genders. Distribution of the study population was so, and as you can see, there was a strong male preponderance. The age distribution was so that the most of the patients presented to us were in the age group of 61 to 70 years, that is 33.3%, and 51 to 60 years, that's the 6th decade of life, patients who were present were 25.3%. This is the distribution of the NIHS score according to the serum albumin levels. As you can see on the basis of stroke severity that is done on NIHS scoring. So the stroke severity is divided into minor, moderate, and severe strokes that which include in the studies.
1 minute left.
Yeah. Correlation of the NIHS score with serum albumin level at the time of admission. As you can clearly see, there is a strong negative correlation in comparison to the serum albumin levels and the severity of the ischemic stroke. Implication and conclusion, though stroke has been recognized from 460 BC, however, it still remains one of the major causes of concern is because of limited therapeutic options to be promptly instituted in the narrow window for treatment because brain tissue suffers irreversible damage almost instantly, resulting in permanent disability. There has been such a search for neuroprotective agents. One such agent is albumin, with recent discovery of its role as therapeutic as well as prognostic indicator for stroke. From the present study, it can be effectively concluded that acute ischemic stroke is prevalent in the older age groups with significant male preponderance. This indicates that low serum albumin levels are associated with increased severity of the stroke. And strokes are of particular importance because ischemic brain tissue suffers necrosis almost immediately and stops working in seconds, giving us a very short window of treatment. While prompt reperfusion. Thank you.
Just conclude. Just conclude. Yes.
Yes, ma'am. The conclusion is that we do not have basically stroke is a condition in which has a very high morbidity and an extremely the disability, the long-term disability has very adverse impact on the population. It might not account for a very huge mortality, but the morbidity that it causes is very high, and it has a very adverse impact on the economy as well. So we need to see what all are the prognostic factors apart from the routine. When we know patients are hypertensive, diabetic, we need to have other prognostic factors in these cases to know what can help us in early diagnosis and early management. So that is why one such neuroprotective function of albumin was sought out and was used as a prognostic indicator. There are a lot of studies going on this as well. And some experimental studies have shown that albumin infusion after stroke onset significantly improves the neurological function and reduces the infarct volume as well. But it's not yet proven. The pathophysiology is not yet certain, so it's still ongoing, ma'am.
So it's a new trend right now where the study
Yes,
is going on.
yes, ma'am.
Okay.
It's a relatively new trend.
Yeah. Okay. So I mean this particular hypothesis, is equal in all the age groups, or hello?
Yes, ma'am.
Is this applicable to all age groups about the albumin and
Yes,
neuroprotective?
ma'am. The study was done, which was include the age group of 25 to 70 years, but there was a very strong preponderance in the age group of fifth and sixth decade of life. Mostly patients in the age group of 51 to 60 years and basically 50 to 70 years age group, ma'am. There was a very strong preponderance of stroke itself. So, but the study was done irrespective, ma'am. Included all patients that we had done from the age group of 25 to 70.
Okay. Okay.
Yes, ma'am.
Did you do a sample size calculation?
Sorry, sir.
Sample size calculation?
Yes, sir. In the area, sample size calculation was coming around the number of 120, sir. But the study was conducted in the year of 2021 as well. So some were the cases, number of cases were limited due to COVID. There was a lockdown period in between as well. So we had to cut short down to 75, sir.
Okay.
Yes, sir.
Thank you, judges. Thank you, Abhishek. We would proceed with the next participant.
Thanks, Vaishnavi.
Yeah. We would proceed with Aditya Moruskar. So,
he's second, right?
Yes, ma'am. Aditya Moruskar is second.
Hello, am I audible, Vaishnavi?
Yes, you are.
Yes, sir. Yeah.
But start sharing the screen, yeah.
Akshay Gupta, can you stop presenting your screen? Yeah.
Is this screen visible? Is it visible, Vaishnavi?
Yes, sir.
Should I start?
Yes, sir.
Good evening, everyone. My topic is first trimester vaginal bleeding and maternal outcomes. Co-authors are Dr. Preeti Hatta and Dr. Pooja Goyal. Introduction. Vaginal bleeding in the first trimester of pregnancy is seen in conditions like spontaneous abortion, incomplete abortion, threatened abortion, inevitable abortion, septic abortion, ectopic implantations, and hereditary mode. Whereas 70% of patients of vaginal bleeding will go on to have a normal pregnancy. It is a relatively common event seen in 30% of all the pregnancies. The objective of the study was to evaluate the perinatal outcomes in a group of patients who had complaints of vaginal bleeding in the first trimester, to study the incidence of antepartum hemorrhage, and to see for the maternal and fetal complications in relation to the gestational age of the delivery. Material methods, it was an observational and retrospective study, including all women who came with first trimester vaginal bleeding above 18 years of age. We had excluded patients with medical condition of pregnancy and ectopic pregnancies, and detailed history and examination was taken for the patients. The information was collected and processed using SPSS results. Out of the total 200 patients, study showed that 70% who came with first trimester vaginal bleeding were of the 20 to 30 years of age, which is a major age group. 24% belong to 30 to 40, and only 5.5% belong to 40 years. 42% of patients aborted, whereas the remaining 58% went on to continued the pregnancy up to second and third trimester. As you can see that 42% aborted as the other patients had 30% had full-term delivery, whereas 28% had preterm deliveries. 30% of the patients who came with bleeding had a similar episode of bleeding in the previous pregnancy, and there was no statistical difference noted. Of the total patients, 56% were primary gravida, that is the first gestation, whereas 42% were multigravida. It was seen that the patients with multigravida, the chances of continuing the pregnancy was much more. P-value 0.022. 76% of patients had comorbidities, and it was noted there was no statistical difference in the patients in continuing the pregnancy. The patient had or did not have any comorbidities. Of the 116 patients that continued the pregnancy, 47% went in preterm labor, whereas the remaining 52% had the pregnancy continued till term. 36% delivered vaginally, out of which 18 were preterm deliveries and 24 were full-term deliveries. 68 patients had to go to LSCS, out of which 34 were preterm, 30 were emergency full-term LSCS, and 4 were elective full-term LSCS. 6 patients had to undergo a cesarean hysterectomy with complications like uncontrolled postpartum hemorrhage and placenta accreta syndrome. 64% of patients with LSCS in the previous pregnancy, whereas 72% of patients with normal vaginal delivery in the previous pregnancy had episode of bleeding in the first trimester, and there was no statistical difference. Out of 116 newborns, 29 required admission in NICU. Two babies had weight less than 1.5 kg, 13 had weight 1.5 to 2 kg, and 42 had weight of 2 to 2.5 kg, and the major 59 newborns had weight more than 2.5 kg. Among the babies who went for NICU admission, the major chunk was of low birth
1 minute remaining.
58.6%. The second share was of meconium aspiration, 20% patient to the babies. The strengths included was a comprehensive study and multiple factors were evaluated. The limitations, it was a pure observational study. The conclusion, considering the results, first trimester bleeding, it can be a predicting factor to know in terms of maternal and neonatal consequences, and hence we can increase the knowledge of pregnant women in this regard for those who present with first trimester bleeding to clinics. Also, that knowledge may facilitate decision regarding management, mode, place, and time of delivery. Sure. Yeah.
Okay. Aditya, the risk which is being observed of this first trimester bleeding is more in which age group actually? Is it middle? Mid-level adults or young people?
More work to do. Like it can be a confounding factor in that, but the major group will always remain 20 to 30 years old.
Okay.
So did you do a sample size calculation?
So sample size came to be 200. Hello?
Aja, 200.
Yes, sir. Out of that, 84.
So what is a retroprospective study?
even I had this question.
Yes. So actually, some patients came in the first trimester itself, like with the complaints of bleeding. We had questions about that, and some patients who delivered, when asked if they had the history of first trimester bleeding, and they had shown to clinics, some private clinics, or they had come to us, we had included even that patients.
That is incorrect. It is totally unscientific. You see, you are looking for very specific things in prospectively when you are seeing the patient. Now, the earlier doctor, they may not have, or they may have seen those, but they may not have noted in the case sheets. No, that methodology is not correct. Anyway, I have no other questions.
That's fine.
Thank you, judges. Thank you, Dr. Aditya. We would have our next participant, Dr. Akshay Gupta.
Am I audible?
Yes, sir.
Am I visible? Good evening, panel and my fellow delegates. I'm here to present my paper on radiographic evaluation in trauma patients under the guidance of Rajesh sir. Trauma is the leading cause of mortality globally, and according to WHO, RTA accounts for million deaths, and it has accounted in 2020 and disability worldwide. The mode of trauma, most of them are motor vehicle accidents and then fall from height. So the classical approach for of any of the ATLS protocol is first the chest X-ray, then the FAST, then MDCT. FAST scan has been is the gold standard previously. That it's a very easy scan. It can identify free fluid in peritoneal cavity and pericardium. Because of its speed, sensitivity, and non-invasive character, FAST was the choice. Because it has high sensitivity of almost 80% detecting liver injury and 100% specificity for detecting the liver injury. The aim of my study is to establish that MDCT is the gold standard technique for assessing and managing abdominal trauma due to its revised sensitivity and specificity, although it has a radiation hazard. My study was prospective study at a tertiary care hospital in the Hawra hospital from May 21 to 22. I had 81 patients out of 103 trauma patients which were enrolled in my study. This included 55 males and 26 females, and the patients were aged from 4 to 53 years with a mean age of 20 years. The exclusion criteria was patients who were very hemodynamically unstable. I didn't take them in my study. A detailed clinical examination and history was documented under the trauma protocol. Fast examination was performed for all the patients. First, to assess the free intraperitoneal fluid and hematoma for MDCT, and then we took the patients for MDCT. Pre-contrast studies were done using a 128 slice MDCT machine. The patients were reviewed, and the CT data was independently reviewed by two radiologists. Hemoperitoneum, vascular injuries, organ injuries were diagnosed, and there were clinical follow-up and serial imaging were done for 75 patients. And as five or six patients were very traumatically injured, they were took for surgical intervention. So these are some of the cases under the FAST examination and the MDCT examination. In the coronal reformatted images, I had a case of a 25-year-old patient with firearm injury, and his kidney was injured. I had a hypodense non-enhancing area, which was measuring approximately 5 mm. Intraparenchymal splenic hematoma with grade 3 splenic injury we gave. It was very evident on CT, but we were unequivocal in fast imaging. We had another case of 27-year-old patients. We took him quickly for the fast imaging, but then we took him for CT as again it had subject variability, and it demonstrated edema leakage and contrast into SAB side or the retroperitoneal space. These are the images which we had. Another 40-year-old male who presented with epigastric pain, and we did his fast examination. We found only mild intraperitoneal fluid with no definite solid injury, but then we took him for MDCT. We found hypodense line traversing through body of pancreas with involvement of pancreatic duct and sparing of pancreatic head. We got grade 4 laceration in pancreas, which we just missed on.
Your voice.
Akshay Gupta, you are mute.
Hello. Am I audible now?
Yes.
Sir, where I left?
This slide. This slide. No. This slide. After this. Yeah. After this.
Okay. So we had most of the patients were made conservatively stable, and which were unstable. Out of 45 patients, we followed up, and patients were promptly taken for splenectomy, surgical repair, and sir, on MDCT evaluation, patients of blunt trauma outnumbered with the patient of penetrating trauma. Motor vehicle accident accounted for 58% of all cases, followed by height. Splenic injuries were maximum, followed by hepatic injuries, followed by renal injuries. Only 2 patients had intestinal injuries, and 1 patient had adrenal injuries.
Sir, time up.
I would just like to conclude that of the inter-observer agreement between me and my fellow for different MDCT findings, we both got excellent subjective image quality on anatomical landmarks and soft tissues and vascular structures, and there was no subjective noise or artifacts. We took as low as radiation achievable for the patient, and the patient with very low dose got very good results for trauma, and there was prompt surgical management for the patient.
So this help you to get prompt surgical management, right?
Yes, ma'am.
Dr. Akshay, good study. But tell me, did you do a sample size calculation?
Yes, sir. So sample size, sir, out of 103 patients, sir, there were many patients who did not. So we were not able to follow.
Calculation. What sir is asking is the sample size calculation for this study. A scientific process.
Yeah, sir. Sir, as we have a hectic.
Doesn't matter. Ajay, you tell me. Ane, that's fine.
Max.
Now, out of these 103 patients, why only 81 were included?
So because so most of the patients, sir, out of 103 documented cases, most of the patients didn't follow up. There was a very vast loss of follow up. Patient were not willing. Some gave wrong phone numbers, so we were not able to contact them.
Okay.
So we were able to study 81 patients, sir.
Fine. That's it. I have no more questions.
I finished it.
That's it. Thank you.
Thank you, sir.
Thank you, judges. Thank you, Dr. Akshay. We would proceed with our next participant, Dr. Shayash Mardolkar.
Am I audible?
Yes, sir.
You can see the screen.
Yes, sir.
It's on slide sharing mode.
It's not.
Okay.
Yeah, now.
Okay. Yeah. Good evening, judges and the organizers of Apophenia. I'm Dr. Saish Mardorkar, the presenting author, and the title of my study is Serum Levels of Magnesium, Calcium, and Vitamin D in Alcoholic Liver Disease Patients in a Tertiary Care Hospital in Goa, which is a case control study. The co-authors of the study are Dr. Chitravai Dhume, Dr. Megha Goyal, Dr. Aishwarya Mohan, and Dr. Bhargav Sawant. So alcohol consumption has shown to have multiple adverse consequences on every organ system, with most devastating being alcoholic liver cirrhosis. These patients not only have micronutrient deficiencies, they also have protein calorie malnutrition as well as electrolyte disturbances. These causes are owing to the fact that these patients are malnourished. Also, there is impaired absorption of these essential micronutrients. In Goa, liver disease caused by alcohol consumption was responsible for 10 to 11% of all deaths registered at GMC in 2013. The aim of this study is to assess the serum levels of magnesium, calcium, vitamin D among patients with alcoholic liver disease and compare these levels with those without alcoholic liver disease. It was a case control study which was hospital-based with a study duration of 3 months. Upon IC approval, the sample size was 120 with 60 cases and 60 controls. And the sampling method which was used was universal census method for the cases. The inclusion criteria was all patients aged 20 to 80 years newly diagnosed with alcoholic liver disease based on clinical, radiological, and biochemical evidence admitted in the general medicine wards of GMC and who were consented to participate. Exclusion criteria of the study were any non-alcoholic causes of liver disease, known case of pancreatitis and on treatment for the same, and who is prior to admission is on any drugs interfering with the study parameters. Age and sex match controls were taken in ratio 1:1 from same wards. After taking consent, institutional ethical committee approval was obtained prior to commencement, and there is no funding and conflict of interest to the study. The results which were obtained from the study were that the mean age among the cases and control was 47 years plus or minus 11.5, whereas and 51.6 plus or minus 12.5 years respectively, and all the cases and controls were males. The mean levels of serum calcium, serum magnesium, and serum vitamin D among cases were 7.39, 1.67, and 9.34 respectively, whereas for controls it was 9.3, 2.1, and 26.37 nanograms per ml respectively. As you can see that there was a statistical significant difference in the mean levels of serum magnesium, serum vitamin D, and serum calcium levels across the cases and the controls, with all three showing with a p-value of less than 0.01. Coming to the discussion, similar studies done by Gill G.K. et al. And also Jalil M. et al. Showed that there was a significant reduction in serum calcium level in patients with chronic alcoholic liver disease, and hence they were more prone to for osteoporosis. Hence, we can conclude that calcium supplementation should be considered in patients being treated with alcoholic liver disease after estimation of serum calcium to prevent osteoporosis in this. Studies done by L. Teruke and Vatsalya V also showed that there were low serum levels in their study, which was concurrent with the study which was done by us. And hence we can say that we need more research in terms of a cohort study to assess the severity of the liver dysfunction in alcoholic liver disease and its association with serum magnesium levels. Also in vitamin D, studies done by Savik Z and Malam M showed that the vitamin D levels were low in patients of alcoholic liver cirrhosis and liver disease. So further research is needed to study the implications of all three, that is serum calcium, magnesium, and vitamin D, and the prognostic indicators in patients with alcoholic liver disease. The strength of the study was the study affirms the existing medical literature on serum levels of calcium, magnesium, and vitamin D, and the limitation, we did not take into consideration the nutritional status and the dietary intake, and we did not, yeah, thank you. Yeah. Yes, ma'am.
Why this particular limitation came in the picture, that it did not assess the severity of the liver dysfunction to correlate with levels of calcium, magnesium, and vitamin D?
Ma'am, actually, we did not correlate with the child pug score, ma'am. Actually, the thing is that if we had tried to that if cases were taken as child pugs, then all the controls, their values were normal, and they had all had a child pug score of 5, ma'am, which was all had a child pug normal. So we could not really say that, correlate the finding. So we did not take into consideration the severity of the liver dysfunction. It would rather, if a cohort study is being done, then we can follow up these patients with reduced calcium, magnesium, and vitamin D and come to a better conclusion rather than saying that comparing based on severity on child pug score with normal and with the cases and the controls, ma'am.
Any prospective study in the literature on this?
There are a couple of studies, ma'am, on calcium, magnesium, and vitamin D. Calcium, there is a contrasting. In some studies, they have found that there is hypercalcemia in advanced liver disease, ma'am, whereas the findings of magnesium and vitamin D are more or less the same, ma'am. It was found to be low.
Your patient group was admitted to the medical ward.
General med. Yes, sir.
Yes. And your control were also admitted in the same ward. So they were.
We don't have a specific ALD ward as such. We have a general medicine ward. So if the patient was taken from bed 1, then bed 2 was taken as the control if he was fulfilling the criteria, sir. If he was not fulfilling the criteria, then we were shifting to bed 3, bed 4.
The criteria was that he didn't have alcoholic liver disease.
Yes, sir, and not any drugs which were affecting the calcium, vitamin D levels, sir, and magnesium levels.
They were not healthy people. They were having some illness.
Yes, sir. We have some cases of a snake bite and a couple of admissions of such cases. Such controls were taken, sir.
So is that adequate? Because when you are comparing biochemical parameters, it is better to have a normal healthy control group. You are having 2 disease groups.
Yes, sir. But since they were the control patients were not having any conditions which were interfering with the study parameter, we thought of taking the same control group, sir.
That you have concluded that from history, or have you done a?
Yes, sir. History, from history. From history and history, as well as we have taken the values, sir, of this for these patients, the magnesium, the calcium.
Magnesium calcium is fine. Did you take liver function test? To ultrasound?
Yes, sir. We have taken the liver function test, renal function test, as well as and these 3 parameters, sir. It was all the 3: renal function test, liver function test, and these 3 parameters were taken in the study, and then only gone ahead, sir.
In the normal controls also. In the
yes, sir. Yes, sir. All 3. If you have taken these 3,
that is not mentioned.
No,
yes,
normal control is not mentioned, right?
No, it is a ill. I mean, they are admitted in the wards.
Yes.
So they will be having various illnesses. My point is, were there biochemical parameters?
Yes, sir. Yes, sir. There are LFTs and RFTs. I have to. Yes, I had to mention that also. Yeah.
Right. I have no.
Yeah. Thank you, ma'am. Thank you, sir.
Thank you. Thank you, sir. We will proceed with the next participant, Dr. Vaishnavi Karpure.
Doctor?
Vaishnavi Karpure.
Right.
What is her number?
Ma'am, I'll notify you in just a minute.
We are writing name anyway.
Hello,
Ma'am,
am I
18th
audible?
number. Yeah, you're audible.
Number?
18th number. 18. Okay. You're audible. Hello, Vaishnavi.
Hello, am I audible?
Yeah, you are audible.
Okay. Good evening, judges. My name is Dr. Vedi. My topic of presentation is, okay, let me just share the screen first. Ma'am, is the screen visible now?
Yes.
Okay. I'm just figuring out. Okay. Okay. So the topic of my presentation is assessment of sural nerve conduction velocity in recently diagnosed asymptomatic type 2 diabetic patients in control group. So as we all know, the diabetes is a metabolic disorder of multiple etiology. It is characterized by chronic hyperglycemia with disturbance of carbohydrate, fat, and protein metabolism, which basically results from defects in insulin secretion, insulin action, or both. So the classic tripartite complication that diabetes presents with is diabetic neuropathy, diabetic retinopathy, and diabetic nephropathy, out of which the diabetic neuropathy is most common complication of diabetes and affecting as many as 50% of the total population suffering from diabetes. The presence of signs and symptoms of peripheral neuropathy, involvement of peripheral nerve with in patients with diabetes, with excluding all other causes of peripheral neuropathy. The chronic hyperglycemia is said to be the key initiator of neurovascular damage. So if you see this picture on screen right now, the amount of iceberg or the height of iceberg that I see on the level of the water is the diagnosis duration that I know that the patient is suffering from. But I don't know for how many years the hyperglycemia has been there in the system, right? So the chronic hyperglycemia is responsible for causing oxidative stress, which ultimately leads to endothelial dysfunction, endothelial dysplasia, causing microangiopathy and ultimately nervous hypoxia. So the objective of my study was to assess the sural nerve conduction velocity in recently diagnosed type 2 diabetic patients and the same in age and gender matched control, and then to compare them. The study design was it was a comparative cross-sectional study, and the population was recently diagnosed type 2 diabetic patients with disease duration less than 1 year. So the sample size was determined considering the sural nerve conduction velocity as the main outcome, and the following assumptions were made while calculating the sample size. The sample size was 17, so 17 participants in each group were taken. Both in target population as well as in control group, convenient sampling was done. Diagnosed cases of type 2 diabetes mellitus attending the study hospital were selected, and age and gender matched controls were also selected in equal number. So inclusion criteria was recently diagnosed type 2 diabetic patient with their diagnosis duration less than a year and falling in the age group 35 to 50 years. We excluded smokers, any cardiovascular or neurological disorders, any peripheral vascular disease, or any vitamin deficiencies. So these are the elements were utilized in collecting the data. Informed consent and demographic data were taken and collected using observation method. So
1 minute remaining.
Procedure. Okay. So in procedure taken on position link and the
You're not audible.
Hello, am I audible now?
Yes.
Hello, is it
Yes, now you're audible.
Okay. So the data was analyzed and coded using statistical software data version 10.1.
Ma'am, there may be some network connection. That's why
I guess there is some technical glitch.
Yes.
Hello?
No.
Okay. Sir, is my slide visible now?
Yes.
Okay, I'm really sorry. So the frequency and percentage was calculated to summarize the categorical variables. I am really sorry, there is some technical glitch. Okay. Two independent sample t-tests were utilized groups, and chi-square test was used to compare the difference in proportions or percentage of the two groups. P-value less than 0.05 was considered to be statistically significant. So in table 1, you see the distribution of the velocity amongst the right lower extremity of diabetic patients and control group. Similarly, in this table, you can see the conduction velocity amongst the control group and diabetic patients in left lower extremity. In this, the latency is being shown in the right lower extremity of control group as well as the diabetic patients. And Okay.
Proceed.
Okay. The strengths of my studies are that it can predict neuropathy as early as within a year of diagnosis. Related measures can prevent development of neuropathy, and ultimately reducing the incidences of non-traumatic amputations in India. Diabetic being the leading cause of non-traumatic amputations in India. The limitations were it was a very small population, so the results cannot be generalized to the entire. The results cannot be generalized. It requires more exploration in this area, and since NCV being a costly affair, we need to do something about the cost efficiency. The conclusion is that sural nerve damage can occur in patient as early as within a year of diagnosis of diabetes, and an early assessment of NCV in asymptomatic patients with type 2 DM can actually detect the probable nervous hypoxia and thus aid in preventing impending neuropathy. Accurate intervention can help restore the blood supply to the hypoxic nervous tissue and thus reversing the damage. Thank you.
Is this a new study, or these studies are there in the literature?
Ma'am, the studies are there in literature, but most of the time the studies were done on geriatric patients where it's very difficult to how do I say it? Whether because of any degenerative changes, the nervous tissue can be hypoxic or the latency can be delayed. So, this was in young patients within 35 to 50 years of age group, where the diabetic cases are mostly seen. So there is definitely the studies are there in literature, but so early, within 6 months of diagnosis or 1 year of diagnosis wasn't done.
Did you note HbA1c?
HbA1c, I guess I know, sir.
Normally nowadays you see all diabetics, they will be doing this periodically. It would be
yes,
useful
sir.
because it reflects hypo or hyperglycemia over a prolonged period.
Yes, sir.
It
So,
will make
yes. So, the literature suggests that it takes around 10 to 15 years for a patient to develop a nervous tissue damage after after the onset of hyperglycemia. But since, as you said, that HbA1c can help us in detecting the duration for which the hyperglycemia has been there in the body. But so what happens is we don't go for exploration of nervous tissue unless or until the patient comes with signs and symptoms of neuropathy. So even if there is, patients with diabetes often go for their checkup, they often go for their regular urine checkup, but nervous tissue or neuropathy checkups are hardly done. If the patient is asymptomatic, they are rarely done. So my study was about in the nervous tissue, which can be later reversed.
Exactly. See, there's nothing wrong with your study. But also noted down the HbA1c, that would strengthen that whether nerve damage that you are saying is due to hypoglycemia or due to some other cause. That is all. Anyway, thank you. No further.
Thank you, judges. Thank you, Dr. Vaidhi. We will proceed with our next participant, Dr. Sundara Singh.
She's number?
Ma'am, I will let you know.
Vasundhara Singh. Non-urethral neoplasms, 15.
Ma'am, 90.
Okay.
Dr. Vasundhara.
One second, I am having difficulty sharing my screen. Just give me a second now.
Okay. Will it be okay if we present it from our side?
Yes, what has happened, Vasundhara?
Good evening, ma'am. Actually, I'm not able to share my screen. Would you please take me in another slot in next person, please? Till the time I'll try.
Okay, Vaishnavi, take next person.
Thank you, ma'am.
Okay.
Thank you, ma'am.
Our next participant is Dr. Vrushali.
Hello.
You're audible?
Am I audible?
Yes.
Is my screen visible?
Yes.
Okay. So good evening, everyone. Presenting you prevalence of fear avoidance belief in patients with low back pain in Indian scenario, a cross-sectional study by myself, Dr. Vrushali Jadhav, first master of occupational therapy from say GSMC and KEMH. Low back pain is a musculoskeletal condition with the greatest worldwide burden of disease. Acute pain is characterized by pain lasting for 3 weeks, and subacute pain is termed as pain lasting from 3 weeks to 3 months, or chronic pain is more than 3 months. Despite both pain and disability being associated with the range of physical and psychological factors, the direct pathway that links the disability remain unclear, especially in LBP. In 1990, Corey et al. Defined kinesophobia as an unreasonable, irrational fear of pain and painful re-injury upon physical movement. Pain catastrophizing is characterized by the tendency to magnify the threat value of a painful stimulus and to feel helpless in the presence of pain, as well as by the relative inability to prevent or inhibit pain-related thoughts in anticipation of, during, or following a painful event. Kinesophobia and catastrophizing are regarded as a salient predictor of pain and disability in chronic pain population and has been identified as one of the risk factors for chronicity in LBP. The fear avoidance belief model proposes an explanation of why some patients with low back pain develop chronic disability. Patients with high level of pain-related fears develop a catastrophic interpretation that activity will cause injury and exaggerate the pain. So the aim and objective of my study was to assess the prevalence of fear avoidance belief and behavior in patients with low back pain, to find out the correlation among fear avoidance belief and disability, to find out the impact or association of pain catastrophizing and kinesophobia on disability among patients with LBP. The study was conducted in an occupational therapy department of a tertiary care center. It is a cross-sectional study. Sampling was used as convenient sampling, and the study was conducted for 4 months. Patients with non-specific LBP who were willing to participate and giving consent of age group 18 to 60 years, both genders were included, whereas patients with orthopedic, spinal, or any psychiatric, neurological, or cardiovascular, or autoimmune condition were excluded. The consent was taken and demographics were noted, and the patient were then assessed on visual analog scale, Auschwitz Disability Index, Fear Avoidance Belief Questionnaire, Tampa Scale of Kinesophobia, and Pain Catastrophizing Scale. The following results were obtained. The study was depicted that among mild to severe disabled group, VAS score was more in severely disabled group. On comparing disability with fear avoidance, such beliefs were found to be high among chronic LBP patients. The study found that pain catastrophizing was high among people with high disability scores. With respect to chronicity, the chronic pain patient had more catastrophizing thinking than patient with acute pain. Coming to the discussion, Hans et al. In 2007 said that the pain-related items are more important factors in development of disability, and so similar results were found that ODI was higher with higher VAS. According to the study done by S. Cordy et al., for fear avoidance belief were higher in low back pain patients. We also found that FAB scores were higher with ODI. Our study results were similar to the study conducted by Franz et al. In 2011 that the PCS score increased with chronicity of the disease. There was strong correlation between kinesophobia, fear avoidance belief, and pain catastrophizing. All these factors are identified as the important predictors of chronicity in patients with LBP. It is now widely recognized that pain has both sensory and cognitive dimensions. Fear of pain and pain avoidance behavior are two important factors that should be integrated in the clinical assessment of low back pain. Thus, Low back pain patient in particular require an approach that addresses both physical as well as the psychosocial dimension of this problem. This modern approach is termed as a biopsychosocial approach. Rather than only focusing on structural causes and cures, this new paradigm emphasizes the goal of maintaining and restoring function in spite of pain. To conclude, the finding of this study suggests that the screening of fear avoidance belief, kinesophobia, and catastrophizing pain is useful for identification of patients at risk of developing chronicity of LBP. These patterns of thinking cause functional impairments and activity limitations, leading to disability in ADL performance and reduced quality of life. Early intervention for these faulty patterns of thinking will help increase the level of patient participation in daily activities, work, and social life. Future direction, future interventional studies on acute LBP are necessary for preventing the transformation of LBP from an acute to chronic condition as well. Thank you.
Okay. So what would you do as a physiotherapist, to take care of all these things like fear avoidance beliefs, etc.?
Ma'am, I'm an occupational therapist.
Yeah, okay.
So, early intervention for the patient who has a fear avoidance belief thinking. So we would include cognitive intervention to correct the abnormal patterns of thinking, which then is leading to catastrophizing of that pain and leading to ultimately activity limitations. So through cognitive intervention, we can alter the correct the abnormal pattern of thinking of the patient.
Okay. Do you think, as a occupational therapist, when you are looking and taking this particular, important biosocial model, even the personality of the person would matter?
Yes, ma'am, definitely.
Okay, in what way? Can you just elaborate a little bit?
So, patients who have developed a different pattern of thinking, who have a difficulty in correcting that pattern, or maybe taking even agreeing that they have developed this pattern, even in spite of the when it is identified by the therapist. So changing that pattern first would be the concern of an occupational therapist, and then including him into the intervention approach.
Okay, I finished.
So would you like to ask something?
See, just one point for my information. Low back pain is dealt with by physiotherapists or by occupational therapists?
Both, sir.
Both. Right.
Yeah. Majority of the patient coming to us complain of coming to the OPD complain of low back pain. So to categorize the patient as a non-specific low back pain, so majority of the reasons are due to the ergonomics that the patient has, and then that leads to development of that mechanical pain. So we as an occupational therapist focus on the biomechanical part as well as the psychosocial part when we are deciding for an intervention for the patient.
Okay.
So that's how we the low back pain patient are considered with us.
Okay. Thank you.
Thank you, judges.
Thank you.
Thank you. We will proceed with the next participant, Dr. Vasundhara Singh. I'll be presenting a PPT from my side.
Yeah.
Is it visible?
Good evening, sir. Yes. Yeah, it's visible. Should I begin?
Yes.
Okay. Good evening, ma'am. Good evening, sir. I'm Dr. Vasundhara Singh, the presenting author, as well as a third-year resident in the Department of Pathology. My co-authors are Dr. Vikas sir and Dr. Ramesh sir in the Department of Pathology at TNMC Mumbai. I'm going to present a paper on clinical pathological profiles of non-urothelial neoplasms involving urinary bladder. These neoplasms, they are rare and the preoperative diagnosis is challenging both for clinicians and radiologists. But speaking from pathologist point of view, it is especially difficult because of the limited biopsy specimen. It is difficult to establish the diagnosis and the type of malignancy, and also to decide whether bladder involvement is primary or secondary is also difficult. So the accurate diagnosis is necessary to plan proper management and therefore minimize morbid effects on the patient. So my aim was to study the clinical pathological spectrum of non-urothelial neoplasms involving urinary bladder based on their histomorphological features. So I studied all the archival specimens of all the benign and malignant lesions from both adults and children that were received in the Department of Pathology at TNMC from January 2018 till June 22. And those were 220 such specimens, including both biopsy and cystectomy. And I studied them based on their histomorphological features, staining characteristics, special stains, and IHC. And urothelial malignancies with focal differentiation of less than 20% were excluded from the study group. As we can see from the table, majority were turbid cases, 9 were turbid and 1 was cystectomy specimen. And the majority of the cases were of squamous differentiation with 50% incidence, and the followed by 30% cases of glandular differentiation. Among squamous differentiation, the mean age was around 63 years with predominance in male, and the most common clinical presentation was hematuria. The most the duration of symptoms were very well 6 years, and radiologically left-sided lateral wall was most commonly involved, and in some cases there was evidence of stones and urinary tract infection. The extent of squamous differentiation is, as we can see in the table, was muscle invasion in majority of the cases, and all were high-grade tumors. Among the glandular differentiation, I cannot see my next screen actually. Yeah, among the glandular differentiation was higher, and muscle invasion was in all the cases, and the grade of tumor was also higher. Could you please move to the next slide?
Next. Is the slide okay?
No.
Next.
Among squamous differentiation on microscopy, as we can see, there were evidence of there was presence of keratin pulse, intercellular bridges, and individual cell keratinization. In the
1 minute left.
The PPT is not following the sequence. Actually, it is going very haphazardly.
Actually, like it would be better if you instruct me where should I when should I scroll up? I don't know when should I scroll up.
Yes, if you instruct Vaishnavi, that will be good. Then she will start moving those, no? Are you there?
Hello, Vasundhara?
Yes, ma'am.
Yeah, okay. So if you can instruct, then she would.
Yes, ma'am, I'm doing.
Next, please, it's like that.
Yeah. Yeah, could you please move to the glandular differentiation slide?
Okay.
Where the heading is glandular differentiation. It's before leiomyoma, actually. Yeah. You're going.
This is
actually.
This. Okay.
This one, the last part of the presentation. Can you go?
Before leiomyoma.
A little back.
Before leiomyoma, this one.
Little more. That's rhabdomyosarcoma. Before that, there's glandular differentiation. You need to go up actually.
Yes, go.
Yeah.
This one?
Yeah, glandular differentiation. Next to the pie chart. Yeah, next to the pie chart. Yeah. Squamous differentiation, most common presentation was hematuria. Among the glandular differentiation cases, predominance was in females. Next slide. And the mean age was around 58 years. And the most common presentation was again hematuria. And on radiologically, polypodal pattern was predominant, and the most common wall was lateral wall. Next slide, please. There was one case of rhabdomyosarcoma in an 18-month-old female who presented with hematuria and pain. On microscopy, we could see cells which were monotonous looking, arranged in sheets, but diagnosis was based on immunohistochemistry. But because of the loss of staining properties, I couldn't include those slides in my PowerPoint presentation. Then there was one case of leiomyoma. That was a 24-year-old female, and on microscopy, we could see the bundles and fascicles of spindle-shaped cells. On immunohistochemistry, it was Ki67 negative and SMA positive. Next slide, please. Next slide.
This is leiomyoma.
So the need for histology, need to study the histological variants is because of their mimicking different varieties of the urothelial neoplasms as well as non-urothelial neoplasms. There could be diagnostic misinterpretation. So the wrong treatment could go to the patient. So identifying the correct histology is necessary so that there's correct therapeutic approach as well as the correct clinical outcome in regards to the patient. So for correct diagnosis, we need, along with histopathology on H&E, we need ancillary techniques like special stains and immunohistochemistry, along with correlation with clinical and radiological findings. That was my presentation, ma'am. Thank you. Any questions?
Yes. Can you just quickly tell us the clinical implication of your study?
Ma'am, because of the misdiagnosis, suppose if one treatment could be treated with partial cystectomy, if we give the incorrect diagnosis, as like if there's squamous differentiation of more than 20%, and we call it squamous cell carcinoma. So instead of doing partial cystectomy, we'll go for radical cystectomy, and then we'll expose the patient to unnecessary chemotherapy and radiotherapy, which might not be actually needed in the patient.
Okay.
So then the correct diagnosis comes into the picture.
Okay, so that's the difference with the correct diagnosis. Okay.
Yeah, also then differentiations are associated to identify the prognosis of the patient. Like there's, as per the literature, there's a higher rate of recurrence and poor prognosis tumors which have higher differentiation compared to lower differentiation. So that is also necessary to identify histological variants as well as the percentage of those variants in urothelial carcinoma.
Any novel findings in your study?
Sorry, sir.
Any novel findings in your study?
Yes, sir. There were cases which had like plain cystitis, like there was no evidence of malignancy. Patient presented with buccal mass, but on limited biopsy specimen in the initial cases. So maybe it could be inaccurate diagnosis. We do not know, because as long as specimen is not available accurately with sufficient amount with us, so there are chances of incorrect diagnosis. So we gave that there was no evidence of malignancy in buccal mass. So because there was very debris present, so we couldn't comment on the amount of invasion. Like we could only see focus of normal urothelial cells.
Okay, thank you.
Thank you, sir. Thank you, ma'am.
Thank you, judges. Thank you, Dr. Vasundhara. We would proceed with our next participant, Dr. Kiran Shinde.
Shit.
Good evening, ma'am. Good evening, sir. I'm third year medicine resident at Department of Medicine, EM Hospital. My study of clinical profile of patients admitted within 30 days of discharge in a medical ward at tertiary care center. So, readmission is defined as patients readmitting within for acute cause within 30 days of discharge from the previous or same hospital. These readmissions are of concern because of their impact, cost, and patient outcome. The circumstances surrounding hospital readmission are not fully known. Poor care coordination after discharge and poor follow-up care are considered two primary factors. Aims and objective to study clinical profile of patients requiring readmission within 30 days of discharge, to study and compare their laboratory parameters at discharge and readmission, to study patients with respect to this index, to study the duration of hospital stay and course of these patients. So, patient methods, the informed written consent of study subject taken after approval from Institutional Ethics Committee. Patient history, clinical features, lab investigation of current and previous admissions are noted. With the help of standard pre-validated semi-structured case record pro forma, investigation are done by treating physician are noted on. Data obtained is compiled in tabulated form for analysis. Data obtained from studies entered in Excel sheets, data represented in the form of tables and charts. Mean median mode were considered to study the central tendency of quantitative parameters. Standard deviation is calculated for variance, and for comparing quantitative data, student t-test were used, and for qualitative data, we use chi-square test. So in this study, we assess the age distribution among the study subjects. So we observed that majority of the study subjects belong to age group of 56 to 65 years, which are 21%, followed by 18% subjects in the age group of above the age group of 66 years. In age group of 46 to 55 years, there were 19% of subjects, and between 36 to 45 years, there were 17% of subjects. In this study, we also compared the age distribution among the study subjects. We observed that majority of subjects for readmission were males, 74.02%, and 26% were female. The male to female ratio in this study was 2.84:1. Comorbidities like diabetes mellitus, hypertension, chronic kidney disease, and other related complications, and complication of cerebrovascular accident, tubercular meningitis, liver cirrhosis, or alcoholic liver disease accounted for most of for higher less index, and the associated with prolonged stay more than 7 years. Unavoidable readmissions noted for chronic diseases such as aplastic anemia due to severe anemia and thrombocytopenia. For
1 minute
CVS
remaining.
with GCS less than 7, decompensated disease in the end-stage liver disease are subject with type 1 diabetic mellitus, which are non-compliant. They admitted for diabetic ketoacidosis. Although faulty diagnosis leads to readmission, but it is not seen in our study. Faulty diagnosis means patient was admitted for CKD, but now came with a DING or etc. So, conclusion of my study: the risk factor for readmission includes the age, male sex, chronic nature of the disease, and associated comorbidities. We can reduce the prevalence of readmissions by proper counseling of patients at the time of discharge and regular follow-ups by the patients. This will definitely decreases the morbidity and mortality, and also the healthcare burden in the tertiary and all the other hospitals. Thank you.
So most of your patients were chronic illnesses, right?
Yes, yes, ma'am. Most of them were having some chronic disease or comorbidities, and for that they are coming.
And the admissions were for the symptomatic, right? Symptomatic reasons or actual
Yes, ma'am.
complications? What is it?
Ma'am, mostly most of the readmissions were for the complications of the chronic disease. Readmissions for single disease like recurrent malaria were very few. For CKD admitting with fluid overload or uremia or other complications of CKD is very common.
Yeah, but that simply means there was a reason for readmission, right?
Yes, 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 ma'am. And we can avoid that, ma'am, by counseling patients regarding the severe the prognosis of the disease or the dangerous signs. So they will come to OPD or other availability and not to EMS and making a readmission.
The readmissions were during emergency or in the normal?
Yes, sir. The patient in this study we have taken patients from wards, so general medical wards. So they came to emergency and they were admitted. Sir, our sample size was 138, but due to COVID-19 pandemic, the readmissions were less as compared to the normal data. So we could get 120 sample size.
Okay.
Thank you, sir.
Thank you.
Thank you, judges. Thank you, Dr. Kiran. We would proceed with our next participant, Dr. Abhishek Singh, Badoria.
He's the first one, right?
Yes, ma'am.
Hello. Good evening, everyone. Am I audible?
Yes, sir.
Okay. Yeah. Just a second. Okay, I'm putting it on the slideshow.
The
good evening,
slides are visible. It's not in yet in slideshow mode. Now it's in slideshow mode. You can start.
Yeah, good evening, everyone. The topic, my topic for today is both bone forearm fracture in adults, a comparison study of LCP and locking compression plating and dynamic compression plating fixation. It was authored by Dr. Gaurav Patel, Dr. Shivam Patel, and Dr. Abhishek Singh. Traffic accident, industrial accidents. Just give me a second. Okay. Traffic accident, industrial accident, natural disaster are all becoming more common, resulting in more fractures and higher morbidity rate in many developing countries. The majority of upper limb fractures involve both bone forearm fracture. When there is a both bone forearm fracture, the mechanism is we require basically anatomic reduction and internal fixation. For that, we go with open reduction internal fixation with plating. Forearm fractures in adults are typically treated with open reduction internal fixation. It is mostly more commonly treated with dynamic compression plates. A dynamic compression plate is used, which has been conventional plating in internal fixation of isolated radius and ulnar fracture for a long time. But nowadays there have been studies showing better results with locking compression plates, which combine the property of both locking plate and the dynamic plate. So it is intended, basically the LCP is intended to maintain the fracture stability while ensuring good blood flow to the bone and soft tissues. It acts as a fixed internal fixator. In the biomechanical studies, the LCPs have been found to provide better mechanical and physiological properties than DCP. The LCP is said to have benefits such as accelerated fracture healing and reducing malunion and non-union concerns. Refractures and cortical porosis in DCPs were thought to be caused by an increase in plate bone contact, which hampered the circulation to the cortex. So to prevent this, the limited contact DCP, that is LC-DCP, was designed to minimize the plate and interference with the cortical perfusion, thus reducing the cortical porosity. Plate bone contact was reduced to non-existent after the invention of the point contact fixators. There is a need for such an implant system that will avoid all of these complications while also providing better functional outcome. As a result, the current study sought is to determine the effectiveness of locking and dynamic compression plates in the treatment of adult forearm fractures. We use the Anderson et al. Grading system to confirm the functional outcome. And also on the radiographs, and the fracture healing is evaluated in terms of bone union. The materials and method. A prospective comparative study was conducted to compare the difference between locking compression plate fixation and the dynamic compression plate fixation in both bone forearm fractures. The study was conducted in my institute, Dr. D.Y. Patil Medical College, Pune, between September 2020 to September 2021, and 30 patients were evaluated.
1 minute remaining.
Were included in the study. All patients admitted in the inclusion criteria was all the patients admitted in the hospital with bone forearm fracture. The exclusion criteria was any forearm compound fracture, any patient unwilling to undergo surgery, patient medically unsuitable for surgery, and age of patient less than or equal to 18 years. We followed up the patient every month for 3 months, and then at the end of 6 months. Okay, according to our inclusion criteria, that's 30 patients with bone wound forearm fracture included in the study. All of them, and 15 of them underwent fixation with dynamic compression plate, and 15 of them underwent fixation with locking compression plate. On an average, out of those, all the 15 patients achieved union in both the cases, and in both the cases, 13 of the patients achieved full range of motion, and 2 achieved limited range of motion. And one patient in both the study groups got surgical site infection. Okay. This is a plain radiograph showing.
Time up.
Okay, okay. I'll just proceed to the conclusion.
Yes. Tell us conclusions.
Okay, the primary goal of the study was to evaluate the functional results of both bone forearm fracture, and for that we saw the radiological union, and we compared the range of motion in both the study groups. In both the groups, as I told earlier, there were in 13 patients there was complete range of motion, and in 2 patients in both the groups there was limited range of motion. So on the basis of in terms of functional outcome, both the patient groups who were operated on DCP as well as LCP had no significant difference. When it comes to fracture union, though, it was statistically non-significant, but the patient operated with locking compression plates had fracture union a little earlier as compared to the dynamic compression plates. We concluded that the use of locking compression plate in the fixation of both bone forearm fracture is preferred over dynamic compression plate in terms of fewer infection, blood loss, and other intraoperative as well as post-operative complications to achieve early fracture union. Proper post and to achieve the proper functional outcome, we need a proper preoperative planning and good patient care as well as proper surgical technique with minimal soft tissue damage, and strict aseptic condition follow-ups and rehabilitation with patients' educations are all required for good functional outcome.
Okay.
Yeah. Okay, ma'am. Thank you, ma'am. Thank you, everyone.
This less time to heal, was this significant or not?
Sir, in the patients who were fixed with who underwent open reduction internal fixation with dynamic compression plate, on an average around 12 to 14 weeks they took to radiologically for us to see the union. And in the patient who underwent fixation with locking compression plates, the fracture union was achieved on an average between 10 to 12 weeks. So it was not very significant, but yes, as compared to dynamic DCPs,
either it is significant or it is not significant. It was not significant. No? You tell the facts. Sample is very small. You need a sample. Fine.
Yes.
Ma'am, any questions?
Clinically, was it helpful in terms of the movements?
Yes, ma'am. Basically, if we go with LCP, so since the fracture union comes earlier, at an average around 1 to 2 weeks, so we can mobilize the patient earlier. So there's complication of stiffness, post-operative stiffness, and all that is comparatively reduced. So that gives a better outcome, and better patients are also like better satisfied with the outcome.
Fine, thank you.
Thank you, ma'am.
Thank you, judges. Thank you, Dr. Abhishek. We would proceed with our last participant remaining, Sanchita Shirore, Dr. Sanchita Shirore. 11th number.
This?
11th number. 11.
Okay, yes, Sanchita Shirure, 11 number,
right. Analysis catheter.
Hello.
Yes.
Yes, you are audible.
Am I audible?
Yes, you are.
Okay. So, good evening, everyone. Let me just start the slideshow. So good evening, everyone. I'm going to present this study conducted under the guidance of Dr. Kavita Joshi and Dr. Yogesh Khandagare, conducted in St. GS Medical College and KM Hospital. So it is a study of clinical profile and outcome of dialysis and catheter-related bloodstream infection in CKD patients undergoing hemodialysis. Introduction. Infections are one of the most prevalent problems of chronic hemodialysis patients. Patients on chronic hemodialysis who have a catheter have a 2 to 3 times higher risk of infection and death compared to patients who have an AV fistula or graft. Catheter-related bloodstream infection is a type of primary bloodstream infection in which an infection exists in bloodstream without any other source of sepsis, such as an organ or other tissue. The subclavian vein, internal jugular vein, and femoral vein are the 3 most prevalent sites. When compared to other central line locations, the subclavian vein has a reduced infection rate. So these are the criteria for CRBSI defined by Kidney Disease Outcomes Quality Initiative. So the definite criteria is same organism is sequestered from the catheter tip and blood culture. Probable criteria is there is differences of symptoms after antibiotic therapy with or without removal of catheter in the setting in which blood culture confirms infection, but catheter tip does not, or vice versa. Possible criteria being differences of symptoms after antibiotic treatment or after removal of catheter in the absence of laboratory confirmation of bloodstream infection in a symptomatic patient with no other apparent source of infection. So objectives of the study being to assess the clinical profile of CRBSI in CKD patients on HD, to find out the risk factors of CRBSI in CKD patients on hemodialysis, to determine the outcomes of HD patients with CRBSI, and to study microprofile of CRBSI and correlation with drugs. Study design was prospective observational study conducted in indoor patients from medicine wards of tertiary care hospital, duration being 18 months. Outcome was death or discharge. Methodology, all defined CRBSI patients fulfilling inclusion and exclusion criteria were informed, who gave informed consent were included. Patient history and examination findings, including demographic data, was recorded. Patient was treated as per standard guidelines, and no other investigations were advised. Additionally, sample size as per the formula turned out to be 120 participants. Inclusion and exclusion inclusion criteria. All patients of more than 12 years of age, patients on HD via catheter who fulfill catheter-related bloodstream infection definition, definite, probable, or possible, patients giving informed consent or assent. Exclusion criteria being currently on other infection, pyelonephritis or UTI, or post-intervention like percutaneous nephrostomy or acute kidney injury. So the results were total 120 patients were screened. Among 120 patients, we observed 71 were probable cases of CRBSI, 36 were possible cases, and 30 definite cases of CRBSI. The conclusions of my study were, in our study, we had high rate of dialysis catheter use with long duration of temporary catheter placement, which resulted in high incidence of catheter-related complications. Therefore, the healthcare administration develops policies to assess patients early. Ideally, before dialysis is required to allow permanent vascular access to be established in advance as soon as possible. To reduce the incidence of HD catheter-related bloodstream infection, catheter insertion should be performed in the following order. First being subclavian, second being jugular, and third being femoral. Tunnel catheter are removed less frequently than temporary catheters. In the study, we observed that 96.7% study subjects were receiving HD 3 times per weekly as compared to 2 times a week. No significant association between interval of HD and CRBSI was found. Hypertension, which is renal parenchymal disease, related to renal parenchymal disease, is most common indication for HD initiation, followed by fluid overload. Thank you.
So what are you trying to say out of this study, Sanchita?
Yeah, so basically to prevent this CRBSI, we have to pre-counsel the patients to get their other options of dialysis like AV fistula or permanent catheter insertion done prior to insertion of temporary catheter.
Okay. And how many patients will be cooperative for this?
Yes, if we explain and counsel them regarding the complications of catheter-related bloodstream infection. And if they are having financial support for the AV fistula or permanent catheter insertion, they are cooperative for the same.
Because many patients come from outside also, right?
Yes, ma'am. In case of emergency, we have to go for temporary catheter insertion. In that case, we cannot do anything much about it. But on those like patients on PKD who have early fall in GFR, that is 7 to 8 per year, we can always counsel them that now your creatinine is increasing and you might require HD soon. So you better get your fistula or permanent catheter insertion done.
Okay.
No questions.
Okay.
Thank you, Judges.
Thank you, sir.
Sanchita.
Thank you. Okay.
We are done with the event today. Thank you, judges, for giving a valuable time to us. And thank you very much for coming in such a short notice. Maybe.
And tomorrow's, you'll send it tomorrow morning.
Yes, sir. Today evening you would send most of the things.
Okay. Thank you so much.
Yeah. So
Thank you.